and you can look at the numbers of diabetes. So maybe like you can call 60 to 70% of the burden of diabetes is in Asia. List of top 10 countries in the IDF Atlas 2021 and 2045 predictions. 6 out of 10 countries are from Asia: China, India, Pakistan, Indonesia, Bangladesh, and Japan. Very frightening. And look at the numbers, what they will be in 2045 with entry of Turkey also as amongst the top 10 countries. So are we really different for diabetes? Yes, physiologically evidence has shown that Asian people are more likely to develop diabetes than their Caucasian counterparts or any other ethnic population for that matter. Even for controlling for body mass index and waist circumference, which means that even in normal weight, South Asians are having a higher risk compared to other ethnicities. Same goes for waist circumference. Estimation of body fat by measurement of waist circumference and waist hip ratio. It has shown to be more strong reductor of cardiometabolic dysregulation and diabetes amongst the Asians. So the cutoffs internationally now defined and regarded for Asians are different from non-Asians. So BMI of 18 to 22.9 is normal. 23 by definition in nation is overweight. More than 25 is obesity. Similarly, for waist circumferences, for Asians, men having more than 90 and women more than 80 centimeters is taken as obesity. Just to show or give an idea of the rampant obesity in Asia, this is data from Far East Asia. Look at obesity in Malaysia, 44.2%, or Thailand, or Singapore, or Indonesia. And same number is stand true for India, Pakistan. Same number is stand true for Qatar and Jordan. This is a very popular slide. Nobody can talk of or complete talk of the Asian phenotype if they don't show Yajnik-Yudkin slide. And what an amazing description here. Both have a BMI of 22.3. Both are diabetes and obesity experts. He lives in the UK and belongs to Caucasian class. He lives in India and belongs to Asian class. With the same BMI, Yajnik looks thinner. But when it comes to body fat of Yajnik is 21.2% compared to Yudkin of 9.1%. And this is the message for Asian phenotype. Liver, visceral, subcutaneous fat in men and women of Asians compared to Caucasians. And studies have found there were consistently higher amounts of hepatic fat among South Asians. Hepatic fat among South Asians, visceral fat among South Asians, subcutaneous fat among South Asians. On top of it, lower muscle mass and beta cell functional capacity of Asians compared with other populations may contribute to ethnic differences. Lower muscle mass in Asians. It contributes to lower glucose reservoir status, resulting in ectopic fat accumulation, which we have shown in the previous slide, and increased insulin resistance when excessive fat and calories are consumed by individuals with a sedentary lifestyle. Gestational diabetes, another marker. Asians are more prone to gestational diabetes than their Caucasian counterparts, and repeated studies have shown them, including even the insulin levels, the biochemical markers for the same BMI, like we have heard about Yajnik-Yudkin, the differences in gestational diabetes for insulin resistance are higher in Asians than in Caucasians. Low birth weight on top of it, which is often due to in utero undernutrition, is prevalent in Asian populations and less linked to higher BMI later on. And in fact, we all know this, from Barker hypothesis. Low birth weight predisposes to diabetes. High birth weight predisposes to diabetes. And in fact, we all shall be knowing this, that our birth weight cutoffs also need to be defined and be defined for Asians, and which are there now. 2.2 kilogram to 3.5 is normal birth weight now for Asians. Because of this low birth weight predisposing to diabetes, then if the catch-up is early, the earlier the post-delivery, postnatal period, the earlier the catch-up is done with weight and BMI, the higher the development of insulin resistance and later on diabetes. Childhood obesity is another Asian problem now, or issue which is more in Asia. 37 million children under the age of 5 are overweight. Almost half of them live in Asia. We did a study ages ago, and our children at that stage were having all biochemical markers predicting towards diabetes. Anup Mishra from Delhi, India has done a lot of work in childhood obesity and in children. And we, at that stage, were alarming the media and through media, the policymakers that schools need to be targeted for prevention of childhood obesity and later stage diabetes. On top of it, Asians may have a lower ability to secrete insulin and thus have less compensatory reserves when challenged with unhealthy lifestyle. So it's a paradox. And because of it, postprandial hyperglycemia is more common. One, because of the traditional Asian diets. One, because of the dynamics of the beta cells and the insulin secretory pathways. On top of all this, when we come to genetic susceptibility, as genetics today was not the lecture, the talk was phenotype. Genotypically, we are also more prone to diabetes, but that is further aggravated, or the main factor are the phenotypic changes which we have discussed. So Asian populations have unique phenotypic traits that affect their risk and prevention strategies for diabetes. Recognizing and addressing these differences allows for the development of more effective, culturally sensitive prevention models tailored to Asian communities. And this is important to realize that when we are talking or representing diabetes in Asia study group, talking in India and Ahmedabad, in Diabetes India, and then majority of the audience and participants being Asians, we need to realize that preventive strategies also need to be defined as per our phenotypic variations and as per our needs, cultural needs, socioeconomic strata, educational needs, ethnic needs, that we shall have our own primary prevention strategies. For massive screening, we are suggesting risk scores. This is how the first step will be for running any primary prevention program in the community to have a risk score. We developed our risk score in Pakistan, obviously with longitudinal studies and validating them. And we have got scores in India, in Germany, in England, but this is our for Pakistani population involving 3 questions. And if the total score is 4 or more, a person is at the risk of developing diabetes. Now, we are educating a primary prevention program on the basis of this score, and it takes only 30 seconds to know if one is at a risk of diabetes or not. And the questions are very simple. The simple questions are age, family history, and base circumstance. I here would like to appreciate Prof. Peter Shavaz for his dedication and commitment to IDF, but in IDF he has got this place because of his dedication and commitment to primary prevention of diabetes. And on this ground he has been to Pakistan quite a few times. In fact, maybe not as many as he has been to India, but yes, he has been to Pakistan 6 to 7 times. Professor late Samashera, Venkat Narayan, Adil Al Sayyed, and Peter talking of primary prevention of diabetes. We are also involving celebrities, actors. Wasim Akram, we know, is a living legend, now a diabetes ambassador, not only for Pakistan, but for the region and globally. And this is, we have launched Pakistan Diabetes Prevention Program, courtesy of Pakistan Endocrine Society, which is one of the largest societies of diabetes endocrine in Pakistan. Similarly, activities are being done in Bangladesh. So this is BADAS and their diabetes awareness campaigns, preventive campaigns, Bangladesh literature for primary prevention. China, having Healthy China 2030 Diabetes Prevention and Control Action Plan. Turkey, the Turkish Diabetic Association starting Arrest Diabetes Project, all in the same line. Indonesia, prevention and control of diabetes in Indonesia. India, launching a national program for prevention of diabetes, cancer, etc. So we know the numbers, we know the burden. No healthcare system in the world can deal with these numbers to provide clinical services on their own resources. And in future, if this explosion continues, then yeah, every government will fail to deliver the health to such billions of people with diabetes. So the only key is understanding the phenotype, the necessity of primary prevention, the strategies to be needed for primary prevention, and to take them further. I'm now coming to my finalist slides that primordial prevention strategies instituted in potential mothers through prevention of malnutrition in uterine childhood, through healthy diets and adequate physical activity. An important additional element. And that's why we have all started to say that if we talk of NCD prevention, if we talk of diabetes prevention, we shall talk of integration of diabetes policies with maternal child health. It's the early programming. We have to think of primordial prevention before we come to this state. I've now discussed some of the RCTs which we know are there for primary prevention. And finally, I'm just summarizing it because we have shown by trials in India, in Pakistan, in Japan, in Germany, in USA that primary prevention studies work. So my final slide is summary of it that we as South Asians, are we phenotypically different? And the answer is yes. And again, the summary is abdominal fat, insulin resistance, high level of C-reactive protein, etc., etc. Because of time constraints, I like to finish off by introducing that now I'm very, very privileged to join Indus Hospital and Health Network, which has main concern for primary care and public health initiatives. They have got mobile clinics, quota-given clinics, mobile vans, mobile hospitals, in fact. They have got boat clinics, and they are talking not only of tertiary care or secondary care, but primary care, public health initiatives, youth engagement, frontline health workers to be developed, community engagement, pre-primary care. And these are the interventions we need to concentrate if we want to have successful primary prevention programs and strategies in Asia. I would like to thank you all. My special thanks to the core group of Diabetes in Asia for inviting me, Diabetes India for organizing this setup. Special thanks to Manshi Sabu and his team. I'm also very grateful to European Association for the Study of Diabetes They have started, and we have in fact got the privilege to have sessions in ESD, and ESD is now invited to DASG platforms. Likewise, increasing collaboration with International Diabetes Federation, South Asian Health Foundation has been great to honor us by their presence. I thank you all, the audience, for your patient listening. Thank you all.
Thank you so much, Professor Basit. For summarizing whatever we have been doing and listening for the last couple of decades. One of the first learning is that we start having a metabolic aberration at a much lower BMI than the Caucasian population, and now we are stuck off with a BMI of 23 kgs per meter square. Second important learning is that as we know, not only insulin resistance is very common in the Asian phenotype, but insulin deficiency sets in rather early. And the third important thing is instead of BMI, probably a waist-hip ratio would be a better predictor of metabolic diseases in this part of the world. Now all of us know, as you know, Professor Basit was showing us the data. I have seen it happening right through my life, a decade, 4 decades life, that epidemic of diabetes coming in the Indian subcontinent. Obesity, which was so rare in the Indian subcontinent. We published some data. There's a global group known as Non-Communicable Diseases Collaboration Group, who have been working together for almost 2 decades. If you just look back at 1975, India had far fewer obese people than even a place like Ukraine. A small nation like France and Poland had more obese people than us. More obese people than us. But today, the data shows we have the 5th highest number of obese men in the world. And we have the 3rd highest number of obese women in the world. After China and United States, India is home to 3rd highest number of obese people. So that's where this metabolic Indian phenotype is worsening. Now, on the one hand, it's very important, this Professor Basit said a very important thing which by and large, invariably we neglect. It is not only obesity which is wrecking us. The underweight, when pregnancy occurs. Today, in the whole globe, more than half the underweight people live in India, Pakistan, and Bangladesh. And it has its own implications on metabolic diseases. Once fetuses are developed in those underweight people, as Yajnik has been telling us for a long time. When I became a physician, whatever scan data was available in 1980-81, we were supposed to have 1 crore diabetics in the country. In just 2010, our group published a paper on this non-communicable disease collaboration group. This 1 crore had become 6 crores. When INDAP study was published a couple of years back, we said we're 10 crores. Our NCD group published a paper just 2 months back. There are 800 million people in the world with diabetes today. Every 4th diabetic lives in my country. And if there's any country which has a worse prevalence than India today, it is Pakistan. Per 100 population, per 1,000 population, per million population. Because you have this two in underweight, pregnancies leading to insulin, and overweight, not being able to handle that obesity. So we are in a much worse situation than we have been. Dr. Basit, I visited Karachi in 2006. I was invited for a meeting of the Endocrine Society of Pakistan. That time I was the president of Endocrine Society of India. Now in this country, in my country, we usually, whenever we have to talk about a national issue or a province, we talk about what is true for Kashmir to Kanyakumari. When I heard about the story of diabetes in Pakistan, I said diabetes does not seem to recognize the borders. The problem seems to be from Kandahar to Kanyakumari. So we need to find common solutions. So we need to find common solutions. To my co-chair.
Thank you, sir. It was a very nice presentation, Dr. Abdul Basit, sir. We usually discuss the Asian Indian phenotype, but you have gone a step further and told us the whole Asian picture and compared with the whole world. So that has shown what Dr. Jargar summarized, that from Kandahar to Kanyakumari, the pattern of insulin resistance and the Asian phenotype looks normal. We have a few important people in the auditorium. I'd like to take their comment in very short. Dr. Kamlakar Tripathi, sir. We have yeah, brief comment. We have Dr. Azad from Bangladesh, and we have Professor Ashok Das. So
Thanks.
yeah.
Thanks, Chair. Thanks, Dr. Basit, for wonderful presentation. One small comment. Dr. V. Mohan Group has separated one group, combined insulin deficiency and insulin resistance diabetes. Now, this group have shown a very higher prevalence of early onset of chronic kidney disease in the terms of proteinuria. And this is the one area in which we are working now, and we have started identifying and to institute some of the molecule which would retard the progression as well as also take care of the podocyte and advancing nephropathy.
And I can see you, everyone can see you, this DSG hall. And we are very happy that our president from Pakistan is right here. And we have with us first speaker, IDF Symposia, which we are starting with, Dr. Peter Swartz. Peter, I will request you to start that session because we are getting late. Please come. So
we thank Dr. Abdul Basit, sir, and conclude the session.
Sure. So we have with us Dr. A.K. Das, sir, Dr. Sarita Bajaj, and Dr. Kamlakar Tripathi, sir. To introduce Dr. A.K. Das to India or Asia, I think I will be fool to introduce. He is my sir. He is our guru. He is legendary figure in India. Diabetes is concerned. Dr. Sarita Bajaj is an eminent figure in India, and Dr. Kamlakar Tripathi, Padma Shri, Sadikot textbook of diabetes. He is editor-in-chief of that, and it's really my pleasure, sir. Both my gurus are here to have it. And we have our first speaker right here. This is an IDF Symposia which we are starting. So Professor Das will be introducing Dr. Peter, and then we start the session without delay because thank you.
My dear esteemed colleagues and friends, and very, very dear, our very dear Professor Bansi Sabu. Dear friends, I will introduce Professor Peter Swartz from heart, not from a paper in my hand. If you want to pick up a person today who is passionate about diabetes, whose every sentence utterance can open up newer vistas for diabetes activity, whose contribution is known for having made a dent in the diabetes care in type 1 and also in type 2, and take the IDF to the next pedestal. He is Professor Peter Swartz. Give a big round of applause for him. He's going to speak next on a very important topic, and he'll be talking to us regarding the very importance regarding the singles vaccination in the, I'll just read the exact title. He'll be speaking to us on the advancing singles prevention strategies in patients with diabetes, challenges and opportunities. I have no audacity to give an introduction. Suffice it to mention, singles vaccine has become very essential in entire population, elderly population, including diabetics. Over to Peter. Peter, all is yours.
Thank you very much. Thank you for this very, very kind introduction. And I would like to say what was said in the introduction is right. My passion is to do whatever we can do to improve the quality of diabetes care for people living with diabetes, and it totally doesn't matter where they are. And to make a long story short, if we really want to improve fast and very effectively the health of people living with diabetes, what is the first step? We should motivate them to avoid carbs or avoid fried carbs. If we cut this down, we gain an enormous amount of health. The second thing is we should motivate them to be physical active because it lowers glucose, it burns down glucose in the muscle cell, and this will improve health. And the third thing is, what is a fast gain of health? We should motivate the people, especially in low and very low income countries, to get vaccinated. Because we know today a vaccination for people living with diabetes immensely and immediately improves the health outcome. And it's a big gap for us as healthcare professionals because we don't recognize, we are not used to it. And this is something we should change. My conflict of interest, I'm working with a lot of partners, and you find industry there, you find a lot of startups there, you find also political organizations, NGOs and funding organizations on there. And as I said at the beginning, the passion I have is doing whatever we can do to improve the quality of diabetes care. And you will find several QR codes on my slides. Many of them go to my WhatsApp channel, and this is a channel where I'm reporting about the activities doing for people living with diabetes worldwide as president of the International Diabetes Federation. A clear statement from the IDF is we know that we know that people living with diabetes are at significantly higher risk of morbidity and mortality depending on the infection, depending where they are. And this is should be become a determinant of driving our work, and at the end a determinant of improving the outcome for people living with diabetes. So as I said, there is a high prevalence of diabetes in India. 240 million people living with diabetes in India. The number is probably a bit too high based on the diagnosis with the oral glucose tolerance test. The number is probably a bit low based on the diagnosis with A1C. Should we fight about the right number? We know there are far too many people living with diabetes, and we are talking about glucose. We are not often enough talking about a 25 years pathophysiology before hyperglycemia, but at the end leading to hyperglycemia. And this 25 years pathophysiology before changes the expression of certain receptors. It develops insulin resistance. And these pathomechanisms make people living with diabetes risk, insulin resistance, or diabetes more vulnerable to infectious diseases, which we can prevent by vaccination. So very high rate of diabetes here in India. And if you look at this rate, how many family households have relatives with diabetes in India, it's the highest worldwide. Even if we go to Saudi Arabia, where we have today the highest prevalence of diabetes, even higher than India, we don't see this family history or family relation to people living with diabetes as in India here. And there are several mechanisms, and they are evidence-based, how the pure presence of insulin resistance and hyperglycemia makes you more vulnerable to infectious diseases. And one of the big examples is COVID. Yeah? You know, the AT2 receptor in people with insulin resistance was 3 to 4 times higher expressed in people having insulin resistance. And this was the big entry door for the virus. And this was a translation for people living with diabetes and insulin resistance having a higher risk of morbidity and mortality during COVID. Before the vaccination, I would say 87% of the people who went to ICU due to COVID and had type 2 diabetes died. If they did not have diabetes, it was less than 30% mortality. So a clear hint, not only a hint, a clear evidence for people living with diabetes having up to fourfold higher risk of contracting infectious diseases. And this is not only for one infection, it's relevant for multiple kinds of infection. And the pathomechanism for this is the presence of insulin resistance. And this is more relevant than the presence of hyperglycemia. And this makes it so difficult. If we say we wait until the people have persistent hyperglycemia and then we think about infectious diseases, it's too late. It's already the presence of early insulin resistance which increases the risk of contracting diabetes, contracting infections as someone having diabetes. I mentioned SARS or COVID, and you see here a threefold increase if you had diabetes to get COVID disease, and an up to fourfold increase to die because of COVID due to diabetes. And again, International Diabetes Federation is very clear, because if we are in Europe and would ask our colleagues whether they agree on what I just have said, they would say yes. Oh, we understand that people living with diabetes have a higher risk in getting infections and they should get vaccinated. And then we ask them how often you talk with the patient about or how often you do it, it drops from more than 90% acceptance that vaccination is important to less than 8% that they do it. There's a very, very big gap where we, on the cognitive level, understand we should do it, but we are not actionable in it. We are not doing it. And this is actually very sad because it would save life of people living with diabetes immediately. So greater awareness on the healthcare professional side is needed for vaccinations. We have to accept vaccinating people living with diabetes will improve their outcome and immediately also improve quality of life for them. And we have to improve our own understanding. We have to educate ourselves. You know that I often like to say prevention, prevention, prevention. In this case, we have to say education, education, education to leverage our ability to vaccinate our people living with diabetes. And why is it relevant? If we are not talking about diabetes, if we get older, we are getting more and more immunocompromised. That means our ability to fight against infection is going down and down and down. If we then have also diabetes with it, so aging and diabetes, we have double, or we could actually say triple hits to get immunocompromised by influencing T cells, by influencing other immune cells. So the response to an infection is compromised, and we would immediately benefit from a vaccination. And one of the infections is zoster. And normally I ask how many people are vaccinated against herpes zoster. And if we are in the European environment, no one raises their hand. And this is something we should and we can change. If we are looking again to people living with diabetes, we see that getting zoster as someone with diabetes significantly increase the complication, especially related to zoster-related pain for people living with diabetes. And you see here an up to 9-fold increased risk of having the complication related to zoster compared to someone who is not having diabetes. Looking into the vulnerability of infections, you see here people without type 2 diabetes and with diabetes, 2.6 to 9.8. So a 3 to 4-fold increased risk of getting zoster as someone having diabetes compared to someone not having diabetes. And this is actually higher than getting cardiovascular disease. So there is a big burden on mortality or it's a big burden on morbidity in this moment, not mortality in the moment, big burden on morbidity due to having diabetes. And if you would say, like for cardiovascular disease, it's difficult to diagnose, it's difficult to treat for people who may not be able to pay for the treatment. A vaccination shot, one shot or two shots, it's easy to apply, it's cheap, and it immediately improves the outcome for people living with diabetes. Zoster-related pain, I mentioned this, is much higher in people having diabetes and zoster than compared to people without diabetes and having zoster. So it's 87% higher in people having diabetes. And I'm not sure that any one of you has experienced this. This can be extremely painful. And again, having a vaccination shot immediately would improve the situation. And as less diabetes you have, as less risk you have, as higher the diabetes risk is, as higher is also the post-neuralgic pain after zoster. And again, giving a vaccination would directly prevent of having these complications. How to do it? It's a double shot. It's a vaccine available. It's FDA approved. In the past, there were two vaccines. One was withdrawn after the vaccine here came because the efficacy is more than 90%, and the other one was taken off the market because it was less than 60% efficacy about years ago. So there's one vaccine available, and it's a double shot for people or for the vaccination. And it gives effective, lasting, sustainable immunization as a zoster vaccine here. In people with diabetes, high efficacy, 90%, and also with other chronic conditions is a high efficacy. And this is unique if you are talking about vaccination. It's higher than we ever had it for COVID and many other diseases. So it's cool to have this for our people living with diabetes. So the Shingrix I mentioned here is effective more than 90%, as is shown here. And look at the age group. It's in all the different age groups the same efficacy. So what would be the right times to start? If you remember the graph I showed you, if you get older, we get more immunocompromised. And there is, so let's say, between 40 to 63 years is the curve going down with the immunocompromisation. If we then have diabetes, it's going faster and the curve is steeper. So 50 years would be a very good cutoff for getting a vaccination for someone who has diabetes. This is a recommendation we very clearly, very strongly have in Germany as well, have in whole Europe as well. And still there are so many colleagues not doing it. I mentioned the 8%. And that's why we highlight this here also as the International Diabetes Federation. It's important to change, to flip our mind into action to do the vaccination for people with diabetes. The cool thing is, if you vaccinate and they get zoster, there are no pains related to it. So you prevent zoster-related pain immediately. So now we all know there's a big stuff going on in the United States. And I looked today in the morning onto this website. And luckily, this organization still exists. Because the new Minister of Health in the United States has clearly said he wants to cut down and he wants to close the CDC. But this is a global relevant organization in terms of driving health promotion and health-related strategies worldwide. And I'm very nervous that in the upcoming weeks we will lose this organization. And if you today look into this organization and look to herpes zoster, what they are recommending, they are making a statement to two vaccines, and one is Shingrix, the other one is Zostavax. And you see here the reason why Zostavax is taken off the market, because the efficacy was around 60%. The efficacy in preventing the infection was lower. So, and the Shingrix is the one with higher than 90% effective and with high efficacy for people living with diabetes. But you could say, I don't care what the CDC is saying, what they doing in Europe. What is the current guideline of Diabetes India saying? Yeah? And here's a clear statement, recommendation of recombinant zoster vaccine in patients with immune-compromised conditions. And that means being older than 50 years is already enough. Having diabetes is a second hit. So we should translate this knowledge, which is very easy to digest, into action. So if you have a patient who is 50, if you have a patient who has diabetes, think about the vaccination. And we are talking about zoster. There are many other vaccinations which could be the same as relevant for people living with diabetes. Coming to the vaccine again, being 50, having diabetes means enough immunocompromisation to that it's becoming relevant for a vaccination. Beside pain, and this is something, if you vaccinate, you know it, the people report about pain for a few days. There are nearly no relevant side effects of the vaccination, which is good for our patient. How to do it? You give a single shot, and within 2 months, you give the second shot. If there are reasons to delay this, you can wait up to 6 months, but as faster you have it together, as better it's for the effect for the patient. And if you are looking again, recommendations of Diabetes India, what they are saying, here down there is the shingles herpes zoster vaccine for people above 50 years of age and having diabetes. You should not only think, you should action a vaccination for these patients. Coming back to the International Diabetes Federation, the driver who should be enough energetic to change our behavior was COVID. Yeah, we have run into the pandemic, and we have seen that our patients living with diabetes has contracted much higher COVID risk than anyone else. They much more commonly died due to COVID because of diabetes. And I must say, in many cases, it was our fault because we accepted hyperglycemia, we accepted insulin resistance, and this was a door opener for morbidity and, in this case, also mortality for people living with diabetes due to COVID. And in the atlas, you find all the information put together how this was globally relevant for people living with diabetes. So as International Diabetes Federation, you should vaccinate people against various infectious diseases, including zoster. And this is not only we should think about, we should action and motivate our governments to prioritize and enable a framework where this vaccination is available and accessible for people living with diabetes and other chronic conditions to immediately improve their health. I'm inviting you to discuss this further at the next Global or World Diabetes Congress in Bangkok. It would be totally cool to see all of you there again and discuss latest developments in diabetes care with us. If you are very active, you have another, let's say, 10 to 12 hours left to submit the late-breaking abstract, because today at midnight there is a deadline for the late-breaking abstracts. We have nearly 2,000 abstracts already for the Congress. There was a very high acceptance rate, so there will be a good discussion about late developments in diabetes care, including vaccination for herpes zoster. There are a lot of phases of people living with diabetes, and a vaccine shot can enable to put a smile on the quality of life for people living with diabetes above the age of 50 years. Let's do it. Let's do it together. Let's follow this QR code. This is the WhatsApp channel I mentioned, and it would be cool to find you there, being interested and keeping contact with me as president of the International Diabetes Federation. But there are also many other channels to be used, and the information is the same or very similar, and I would love to stay in contact with you. If you get everything what you have here today, keep this. People living with diabetes should get vaccinated. And let's work together with all our ideas, all our intention, all our passion and commitment for people living with diabetes, and help our patients that they get vaccinated away from shingles. Thank you very much for your attention.
Thank you. Thank you, Dr. Peter. Any question, any comment? Okay, thank you. So now we have next speaker, Dr. Elena, and she is from Ukraine. We'll be talking on forgotten or few delivering cost-effective diabetes care. She is a pharmacy graduate, associate professor, vice president of International Diabetic Federation, has been responsible for scientific editor of pharmaceutical journal in Ukraine, member of European Medicine Agency and EMW steering group. Lot of credential, lot of credit, and at least should be talking on this important issue because what has been raised before, a lot poor community in our country and all over there, Southeast Asia have this problem. So over to you for looking cheaper medicine, manufacturing, and making popular.
Thank you so much. But I would, before my talk, thank you very much for introduction, kind introduction. But before I would like continue, Peter, your point that we must vaccinate our patient, our people with diabetes is very, very important. But how we can get this, who help to us, like a healthcare professional, is also my subject. In this case, we have a lot of pharmacists, because not too much doctor endocrinologists who have a lot of patients, and it's not possible all the time speak every month and sometimes, but who can do this? Pharmacists. And International Diabetes Federation, we collaborate with Pharmaceutical Association, Federation in the international world, make tools for pharmacists how to do this, what is need, which vaccine need, and this is very important because patients go to pharmacy every day, and a pharmacist can ask about status and recommend this, and then he go to doctor. This is very important collaboration with pharmacists who can assist doctor. This is what I would like to add to your very important point. And now I go to my speech. We will speak about, first of all, I forgot. First of all, I'm very happy with you. Thank you very much to Diabetes India, to all of your team, and especially Dr. Banshi Sabo. Diabetes India is the best congress in the world. You know, I'm absolutely sure. It's not compliment. I am from IDF. I must be say that IDF, but now maybe this in Bangkok will be best. But now in the first position, Diabetes India. Yeah. And today we will speak about cost effectiveness diabetes care. I will try make specific practical solution for your practice. It's not easy topic because, you know, we have a lot of drugs, and it's sometimes we lost and miss what we can do. And also a lot of new product. If you look in burden of expenditure of economic impact on diabetes, you can see how during the last 15 years it was really increased. And indirect cost consists 35% of annual global health expenditures. And we have some model built using epidemiological and demographic data, as well as recent gross domestic product for a cost for 180 countries. And this model show that global economic burden of diabetes in adult projection from 2015 to 2030 will increase from $1.3 trillion to $2.5 trillion. You can imagine. I don't know what is how it's money, how much is money, but this is terrible news. But before we will speak about cost effectiveness, we must know something in terminology of pharmacoeconomic. I only kindly remind your knowledge that what is direct cost, we know the service, drugs, medical supplies. Indirect cost is everything include related to patient care, and incremental cost effectiveness ratio we use for dedicate difference in cost divided by difference in outcomes, and a very important quality adjusted life year quality. Now, this is a measure of disease burden include both quality and quantity of life lived. It is used in economic evaluation. It's very many research do this like specific point about quality, because quality equates to 1 year in perfect health. And as I say, availability and affordability of medicine. And availability is like what we have on market, and affordable what we can use really, like economic aspect. Evaluation, economic and clinical burden. You see, it's only one example in Sweden. They evaluate this, and they see that it's very substantial, but could be reduced by early and effective treatments to achieve glycemic target. Without discussion, we know everybody, the complication prevention and glycemic control are the most effective ways for save money. And if you see, this is a lot of evidence we have already seen. If you look 30 years cost effectiveness and alternative strategy of achieve excellent glycemic control in type 1 diabetes, is also show to us that less HbA1c, less complication, better quality of life, and this is bring to its goal to cost effectiveness. If you speak about type 1 diabetes and they use insulin, the use of intensive insulin and devices as a general treatment strategy will reduce the cost effectiveness of intensive therapy unless they achieve better clinical outcomes. But at the same time, another research shows that cost effectiveness of intensive glycemic management depends of age and duration since the diabetes diagnosis. Intensive therapy using pump with GCM is not currently cost effectiveness as general treatment strategy, because of course it is a big cost of this equipment. Pump therapy with CG may still be an appropriate therapy for selected patients to have poor glycemic control and problematic hypoglycemia, and who achieve improved long-term outcomes with such therapy. But I would like to add something from my side, which I know exactly because I'm a person with diabetes and use different devices during my 30 years with diabetes. And of course, we must think also about mental status of patient. It's technology completely change the status, and a person more free, feel free in life. And now practical solution. And if you speak about some drugs, semaglutide versus insulin aspart, that 1 weekly semaglutide in 1 milligrams projected to be high cost effective versus insulin aspart in treatment type 2 diabetes in the UK was. If you look in CGLP-1 semaglutide versus dulaglutide, liraglutide, we see that oral semaglutide is predicted to offer health benefits similar to substantial semaglutide ahead of dulaglutide and liraglutide. Oral semaglutide is cost-effective GLP reception agonist treatment option. Another long-term cost-effectiveness study, semaglutide 1 milligram versus dulaglutide 3 and 4.5 milligram, also was in the UK, shows that semaglutide 1 milligram represent a cost-effective treatment versus dalaglutide is this dose at 3 and 4.5. In UK this was. Semaglutide, small dose like 0.5 milligrams and 1 milligrams versus dalaglutide 1.5. Compare with treatment with dalaglutide, once weekly semaglutide represent a cost-effective option for treatment individuals who cannot achieve glycemic control with metformin. Another small dose research in Japan shows that one semaglutide in small dose in cost-effective treatment option compared with one weekly dalaglutide 0.75 milligram. Look, combination. We spoke about combination in great session about primary care, and we see that oral semaglutide plus metformin seems not cost-effective versus empagliflozin plus metformin in patient uncontrolled in metformin. This is we can also must know and your choice. Semaglutide versus sitagliptin, emagliflozin, and liraglutide. Oral semaglutide was estimated to be cost-effective compared with liraglutide versus sitagliptin, and background there alone, but it did not meet their hold compared with empagliflozin. Cost-effectiveness analysis of dapagliflozin in treatment high-risk patients with type 2 diabetes in UK. Compared to placebo appear to be cost-effective. The finding highlights the potential of dapagliflozin to have a meaningful impact in reduce the economic burden of type 2 diabetes, and this is of course associated with complication. Cost-effectiveness analysis of empagliflozin therapy that shows that it's better. Empagliflozin, in addition to standard care, is projected to be high cost-effectiveness study in UK. And if you speak about SGLT2 for type 2 diabetes, and this is be cost-effectiveness compared with many antidiabetic therapies, includes DPP-4, sulfonylureas, thiazolidinase, alpha-glucoside inhibitors, and insulin even. GLP, CGLT2 and DPP-4 versus more oldest therapy, of course, it's more cost-effective. If you see, demonstrate also, this is, you know, it's you listen a lot of lecture about reduction of cardiovascular and renal complication if we use CGLT2. Cost-effectiveness CGLT2 versus GLP-1, DPP-4, another, it's a review. The study that discovered that, of course, CGLT2 was more cost-effective than GLP-1 in type 2 diabetes. Another example is not about anti-diabetic drugs. It's about another, that for primary prevention, statin use has been found not to be less cost-effective like prevention, primary prevention. Another bariatric surgery was cost-saving among individual with type 2 diabetes and overweight, likely due to larger health risk posed by obesity. This is what I did in Ukraine. It's my subject, like pharmacoeconomic, and we have many medicine in market. It's available, but if I account affordability, it's not too much. And this case, we have a lot of medicine, but finally we cannot implement modern schema. This is a big gap. And another aspect which also influence on economic burden and cost effectiveness. This is medication adherence. As you see, a 20% increase in adherence can save 1,070 in total healthcare spending for each patient type 2 diabetes. It is important to educate patients that saving money today but not adherence to the treatment may mean spending much more money in the future. This is like in dancing. Physical, and this is also interesting. Everybody speak about mental health and how psychology can help to us, but you see, for type 2 diabetes, there was evidence psychological intervention improved dietary behavior and quality of life, but not blood pressure, body mass index, or depressive syndrome. This review suggests that psychological treatment offer minimal clinical benefit in improving HbA1c level for adult type 2 diabetes, and the researchers cannot find any evidence that any benefit, clinical benefit with control intervention in improving GLC level for type 1 diabetes. Economic about safety. Globally, the cost association with medication errors has been estimated at US $42 billion annual dollars. And you see, it's a very important safety, and it's a lot of resolution about patient safety. This is also we must thinking about this, and when we prescribe. About therapeutic inertia. Achieve early and intensive glycemic control therapy. Minimizing therapeutic inertia can lead to substantial saving for society, ranging between 9.6 million to 51.4 million euro. This is big problem like therapeutic inertia, and finally this is like slide like this is complex which influence on cost effectiveness like safety, adherence. If it's adherence, you must provide good consultation. I would like recommend read this or listen in other our colleagues which have already presentation about good consultation, Dr. Rashid Kasari, and about inertia, clinical inertia. Balanche Chidambaran, sorry if I'm not right. And of course, price of insulin and glucose lowering drugs. This is a very important issue, and this is what we work on this in a global level with WHO, with manufacturer, and this is a lot of stakeholders must be together for decrease price, because without this we cannot deliver to all people who need diabetes, who need drugs. Biosimilar is one way for reducing on price human and analog insulin by increasing complication. As member of European Medical Agency, which subject will biosimilar, I recommend go to this site, and you can find very practical recommendation for you, and also material which you can use for consultation people with diabetes, because they provide not only for healthcare professional guidelines, but also material for patient about biosimilar. It's more easier because, you know, sometimes they reject, they afraid this biosimilar because it's not enough knowledge. We must also provide this knowledge. It's one option for decreased price. Decrease of cost way for prevent the adverse consequences of diabetes. It's promote awareness about diabetes, promote lifestyle change and patient education. You see that the use of diabetes self-management education is associated with low total medical cost and low total prescribed medical cost. And pharmacists, again, this is, I would like strongly recommend make cooperation with pharmacists. Use this cooperation because it's make easier your work. They only help to you. And I, like Peter say, invite you to our Congress, and this is on this Congress, it will be first time section about pharmacists in diabetes, but it's not about them role, about how we can collaborate, what is how we can do together and achieve better outcome for people with diabetes. Thank you very much for your time. And if you're interested in this economical research, please ask me. I will be happy to help because this is my subject. And I'm sure it will be very interesting collaboration. Thank you very much for your attention. I'm in time.
Thank you. Thank you, Irina, for that wonderful lecture. And of course, very thought-provoking as well. So it's a privilege, an honor to invite the current chair of IDF Southeast Asia, Dr. A.K. Azad Khan, who has many degrees from across the globe, from London, from Basel, Switzerland, and he's honorary president of several societies. And I think almost for half a century, he has been involved with the Diabetes Association of Bangladesh. Dr. A.K. Azad Khan is talking about how Southeast Asia region can be strengthened to improve the care of diabetes. So I think Banshi has planned this session meticulously, keeping the theme of Diabetes India in mind, to make diabetes care accessible, available, and affordable. Over to you, Dr. Azad Khan.
Thank you for the kind remarks, Professor Sarita Bazar. First, please allow me to thank the organizers, especially Banshi, for this kind invitation. My talk is mainly concentrating on two things. Number one, how to organize diabetes care in countries where there is no universal health care, in lower middle or middle income countries like Bangladesh. And secondly, IDF president was here. Is he here now? No. He has been saying, he has been saying that we know a lot of things about prevention, but we are not yet able to make it practical, is prevention. So my talk is on that. You see, I come to the UN Declaration 2006 that made the UN Day for Diabetes. You see, it's just not a simple piece of paper. That's what you see. I take pride that these UN resolutions are initiated officially by my letter, but you can see that that's not a simple piece of paper. In fact, it has requested all member states and associated organizations to take up national policy for prevention, you see. And now you ask yourself, how many countries or organizations have really taken national policies for prevention? And this pandemic is mainly largely due to type 2 diabetes. I shall not go through the figures. Southeast Asia have already known that it is the not epicenter, it is the center for type 2 diabetes. And major barriers for organizing diabetes care in Bangladesh, means this sort of countries, is lack of adequate manpower, lack of many things. So you all know this. But in view of this background, Bangladesh Diabetic Association you can call an exception, that we have organized diabetes care. The association looks after more than 80% of the diabetics of the country. We have our presence is through all the districts in Bangladesh. There we have got an association, and we together form main association affiliates. So our motto is that all diabetics will be treated, and they will get job, employed, and they will not die of hunger. You see. So that's our motto. I don't think we have been able to achieve that 100%, but like having insulin for type 1 diabetes, that we have achieved. This innovative program is, you see, I said that one of the main shortcoming is the having appropriate manpower, and we have tried to overcome it by certificate course on diabetology, certificate course for paraprofessional, certificate course for diabetic educators. And I dare say that we have trained till today more than 18,000 GPs on diabetes. So guiding principles of Bada, we call Ibrahim model, that's from the name of the founder. But you can see the bottom line I have just said, diabetes prevention, it was adopted before UN resolutions. See, our institutions at the central location, Bardem, you all know it, but then I shall go through them quickly, you see. We have got nationwide diabetic registry, so it will facilitate complete online care, you see. And it is available now, online care, but although we have not been able to bring all the people under online care, one of the difficulty in Bangladesh is that to take expert medical care to remote areas, you see, remote areas. But this online care will be able to overcome it, you see. So I come to this. So this online care that we have started comprehensive digital care center, and we have piloted in 3 areas. It seems to be this, and soon we will be opening more. So in the end, we shall be opening about 300 throughout the country, you see. And then to man those online care centers, we have trained a group of people we call physician assistant, which is like lawyers have lawyers assistant. So we have physician assistant who will be available in these remote centers and who will be supervised online by expert physician. We have tried universal health coverage, you see, in more than 25,000 government workers, and we found it is feasible. It is practical. So 4 years back, we did that in, as I said, 20,000 government workers at a cost of about $8 a year. But mind that government workers are young, healthy, and they are certified healthy, so they don't normally get disease. You see, if you do it in general population, it will be much more than that. But point is that it is feasible. In fact, it may be the present government of Bangladesh will take up universal health care. I may divulge this, that I am the head of the Healthcare Commission, and that's what we're going to recommend it. We have made a mobile van, so that will provide care in very inaccessible areas, you see. Then we are coming to the prevention. That's the one I want my president to really give attention, you see. As I said, all the factors for prevention are not known, but we know lifestyle intervention and chemo prevention are evidence-based, which are known. And lifestyle prevention is far superior than anything else, that we also know. But these evidence-based DM prevention, I'll go through it. And these are prevention is highly cost-effective. We have done cost-benefit analysis. It is highly cost-effective, like even in developing countries. You see this. So the national policy for the prevention that we have adopted in Bangladesh, we have submitted this to the government. You see, it's an important. You see, like if you think that fast food contributes, you see. So now in European countries, you don't allow fast foods to be advertised near school children's home. But in Bangladesh, all fast food shops are near children's school, you see. So that means you don't have to be only create awareness. You have to have rules by the government. Because countries like Bangladesh is not easy, you see. When there is a parliament in Bangladesh, it's mostly by businessmen. And they do business with fast food, you see. So see how complicated it is. But the thing that I have shown It is only political commitment. To implement that, it does not involve any money from the government. So now the question that I want to raise attention to my audience is that using the right language and right motivation, right medium for the motivation. You see, we are all saying that we are trying to prevent, and we know people, we are advising people, but they don't simply listen. But come to this, you see. Who doesn't know smoking is harmful here? Would anybody raise hand that doesn't know smoking is harmful? But I believe some of you must have taken a puff in your life. And then to begin, to start with, is very highly unpleasant. But think that how can the tobacco companies still able to recruit people for smokers? You see, here I'm showing some examples. You see, Reagan smoking. You know, the heroes in India, they are smoking. So they have taken this sort of means to this. And I think we, the medical community, must give attention and do research to find out right language and right medium. Otherwise, you will not be successful, you see. And I'm going to show here that some of the things that we have tried and found highly successful. You see, Bangladesh is predominantly Muslim country. So we contacted all the religious leaders, it's Muslim, Sanatan. Sanatan means Hindus and Christian, you see. And Bangladesh Christianity is more than 90% Roman Catholic. And since requested them whether they are going to help us. And from they all agreed to help. But in Islam, there is a strong message for good health in their religion, you see. So that made us easy. So we, and they, you know, on the Fridays, the Muslim congregates in the mosque, and there the Imam gives a sermon, which is called khutbah, you see. So we tried to put this into their khutbah. So we recruited highly educated religious leaders and formed khutbah and got it authentic. I'll just go through quickly, see. And got it authenticated by Al-Azhar in Cairo, because their fatwa is taken to be somewhat official in the Muslim Sunni world. See. And then we sent it to the Grand Mufti of Kaaba and then got it authenticated. And we were able to persuade the government that they pass an order that these mosques, we selected certain mosques that this is given. And we found that it has quite a big effect, you see. So then we did a control study. So you can make it double blind with some mosque where it is given and some mosque where it is not given. I'll just go through this. And then in fact it has reduced incidence of diabetes in 1 year by more than 40% in this population. And you see, in Bangladesh, the women do not go to mosque. So we recruited the Imam's family, his wife, his daughters, to persuade the ladies to do it. I'll go quick through it, so I'll leave a lot of time for discussion. So this was one aspect. Second thing was that can we reduce GDM? So people have all started, GDM started with pregnancy. So we thought, why not start at the time of marriage, you see? And I dare say, you know, I hope the Europeans wouldn't mind that in subcontinent as a whole, the children are born through marriage. I mean, I'm not saying that children are not, a few may not be born through marriage, but then will not be accepted in the society, you see. Because everybody has a father, you see, actually. So there, the person who solemnizes marriage is called, marriage register is called Hakim. So at the time of solemnizing a marriage, he gives a message that God has given us knowledge by which we can plan pregnancy. So there should be no unwanted pregnancy. That's one. And also we gave them message that before you contemplate pregnancy, get the lady checked for 6 things and correct it before you do this. So I'll take through 3 minutes. So this is we call pre-conception care, and we found that it has reduced GDM more than 30% this pregnancy. So I'll just go through it. I'll not go to the causes performance. So another thing we were able to achieve that this marriage contract, the Muslim marriage is like a business contract. So in this contract will be given official seal. The message has been received. That was the passed by the government. And then I'll go. This finding was selected at the UN high level meeting. And you see. So I will come to the end of the slide. These are the figures that you see. This message has become a self-sustaining project. You see. And I'll just come to the last slide. And then we are going to do, amongst other religions, we have already started, but then do control study other religion. So the other study that we have done is, they group together participatory learning cycle. So we are highly successful to reduce infant mortality and maternal mortality. So we did that with diabetes, and also we found it highly effective. So these are the figures shown. So now I conclude, prevention of diabetes is feasible, but you have to find the right language and right medium and the right method. Thank you.
Thank you. Thank you. Can we have all these three speakers back for question answer? Can we have two more extra chair here? आप इधर आइए। Two more mics. Yes.
So the house is open for questions and answers. And I think while you are still deciding as to what to ask, yeah, excellent.
Don't be shy.
So the excellent lecture by Dr. Irina. Though she had a language problem, she came from Ukraine, but she gave us an unusual observation that psychological health, in spite of these medicines, do not improve the blood pressure, which we all thought. Can you elaborate on that, please, madam?
Sorry. Can you repeat?
Как можно это психологические медицинские не работают давление?
Was research. It was not my research, but I only think that we sometimes too much speak about psychology, mental health, and something like that. It's not so big in input to clinical effect, but of course, some person need help in this also. But it's like I present research. It was not mine.
Thank you.
Thank you for your question.
Peter, I was just wondering, of course, I really loved the way you spoke yesterday also, just before the inauguration started. And what you said is that if we are not better promoters, like, see, the media is so active, but we should be able to promote better. We should be smarter than them. And I love that what you said. And the other thing I have about, I'm not sure what sort of habit I would label it. Like you said, vaccinate, vaccinate, vaccinate. You said it's 3 times. I'm one who was, said 10 times over. But, the question here is the problem is we need to not only prime the physicians, but public as well. And it has to be done, I agree with Dr. Azad, it has to be the right time, the right medium, and country specific. It cannot be one size fits all. So that is the problem. How can we address that issue?
I think that it's difficult should not be an apology that we are not doing it. I'm leading an initiative, we call it Coalition for Vaccination in Germany for people living with diabetes. And actually, it's a disaster, our own behavior, exactly like you say. We know that the people will immediately benefit from vaccination. We know that it will save life for the people living with diabetes, but we don't do it. And there is no excuse not to do it. Of course, we remember all this discussion about COVID vaccine. It has this, the political and public discussion about COVID in some countries has destroyed the good intention about vaccination. And I think we have to come back to our evidence basis, because if you look into the evidence, then if you forgot one patient to vaccinate, it's already a failure. And the numbers I mentioned, in Germany, it's only 8% of the diabetes patients who are vaccinated. And this is, it's a disaster. And of course, we have to educate ourselves. We have to become ourselves confident to vaccinate. It's not only education. 50% of our colleagues say, no, vaccination is not so important. Now imagine the Minister of Health in the United States having a very different position. This is a disaster for the global vaccination strategies. And so that's why I want to say it again, vaccinate, 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 because this will save life for people living with diabetes.
I'll say it another 7 more times. Could you please introduce yourself and ask the question?
I'm Dr. Jayaprakash from Hyderabad. To Professor Azad Khan, sir, it's amazing that you have done initial screening, awareness, education to the general population. Post-treatment, regarding their monitoring and medication, is all the patients are covered free of cost, or any data is there that the monitoring, how it is done in preventing diabetes complications? Thank you.
If I have understood your question correctly, our model is cross-financing. The model that we developed in Bangladesh, to a large extent, the institutions were built through project financing. That means projects was subsidized by the government to finance the capital development, but then we run it by cross-financing, you see. So that means poor people get it free, but the rich people, they pay something. But the rich people, they pay something which will be less than private care. But that is possible because of the government subsidy that we received. You see, that's the way. Here, I hope I have answered your question. Have I answered your question?
Yeah.
Yes. Now, I'm just trying to make a comment of Peter's. In fact, I think in India also, in Bangladesh also, in Bangladesh, of course, even the diabetics are not vaccinated for pneumonia. Which I think,
Absolutely, I agree, and that's true.
Physicians' inertia. Not the patient do not know, but we also do not promote it.
Yeah.
No.
So what I'm saying that in Western world, all people after certain age, they get diabetes, no diabetes, they get pneumonia vaccine, influenza vaccine. But here, even general population are not vaccinated on those, you see, except they used to be vaccinated for smallpox, but that is eradicated.
No, but other vaccines are in place.
Yeah.
Because parents will ensure that the children are vaccinated.
Yeah.
But who will be playing the parental role for the patients with diabetes?
Yeah, that's
so
right.
we, the doctors,
Yes.
isn't it? So
Yes.
we need to be aware first, and then the implementation is at a second
That's
level.
what I'm saying.
Like
Should be given emphasis to it.
Peter is saying that we are not convinced enough to start off. So there, I don't know, like you said, inertia, not willing, don't want, don't care, too much work. There's so many excuses. But I always say, find an excuse to do the right thing rather than find the excuse for not doing things. That is the way to move ahead.
I'm 100% supportive. And I want to use the same example I gave yesterday. If you think about blood pressure, every one of us is agreed to lower blood pressure to a normal extent to prevent cardiovascular disease. And we say this is evidence-based. The evidence for saving life is actually higher by vaccinating people. Not only zoster, all the list of I have shown with the Diabetes India recommended vaccination, and we are not doing. And what happens with us that on one side for blood pressure, we are very open and we treat and we prescribe triple, quadruple combination, but for the single or double shot of vaccination, we have this inertia. And this somehow is odd. And this is something we have to fight against. There are good examples in Portugal and Brazil. Also during the COVID pandemic, there was no problem at all with vaccination, but they experienced the United Nations vaccination campaign with polio and so on in the last 20, 30 years. So they have experienced the good effect of vaccination, and maybe we have lost this memory. And this is something we have to change, and this is something the International Diabetes Federation will fight for.
Please go ahead. Your question.
Thank you, Sam. Dear Peter, thanks very much. Thank you very much for your emphasizing the vaccination. Well, this is for both type of diabetes, type 1, type 2, which is better for prevention, type 1 or type 2?
This is an interesting question. Is it more relevant for type 1 and type 2 diabetes? I don't know how is the situation here in India, but in Germany, it's again an odd story. Type 1 diabetes patients are much more vaccinated than type 2 diabetes patients. And I would argue, but this is, I don't have a study for this, this is more my clinical gut feeling, because the patient is paying more attention to his own health, and he is working more closely to the physician that the translation of vaccination into action is better in type 1 diabetes patient. In type 2 diabetes patient, it's a disaster. And as I said, we have to fight against our own clinical inertia to change this, because as I said at the beginning, the fastest gain of health is skipping fried carbs, physical activity and or fasting, and vaccination. And this provides an immediate gain of health for the patient.
Thank you.
Yeah. Go ahead.
Peter, the point about this seamless vaccine, my experience is that it is only a cost that is a hindrance, because it costs around 110 euros in India, and what I have been experiencing that empagliflozin and linagliptin combination, when it came in India in 2018, it was almost 77 rupees per tablet, and I used it and my patients were very happy. So if the cost comes down, it will be probably the physician inertia will be also lower, and they will try to use it more. So how about that point, please?
I would say the clinical inertia is not coming from the price from the vaccine, and it's a different level. But you are totally right that the cost is an issue. And this is something International Diabetes Federation is also fighting a lot. If I presented this one vaccine for zoster here, it's because it's the only one worldwide existing. And of course, the company comes and said, if you are the only one, we can get a better price. We have to force this company to adopt to their social responsibility in providing available and accessible healthcare to anyone worldwide. And this is a long way we have to go. And it's not that IDF alone can go. We as community of people who are passionate for providing this care have to go. And I don't want to extend it too much. We have in the diabetes sector currently big companies who withdraw cheap insulins globally from the market. It's unacceptable that this happens. They don't adopt to their social responsibility. And this is bad. And I think we have to put the finger in this wound to tell them that it is bad. In this case, with the vaccination, we have to friendly force the company to provide opportunities in different markets, maybe also having different prices. So we have to understand the need of the company, but we have to force them to understand the need of the patient as well.
So I think that's brilliant. I would like to just add, when you were talking of cost effectiveness, that brings us to Irina's talk. See, when we talk of cost effectiveness, see, if we prevent shingles, or if we have lesser side effects or pain, like he was saying, that itself overcomes that. So that what you were addressing, cost effectiveness of any molecule, the basic crux of the matter is to control the blood glucose by hook or by crook. If we can achieve that, then we hopefully delay, prevent some of the complications, right? So those complications, see, by the time the complications occur, the patient has already left the endocrinologist or diabetologist. They go to the nephrologist, they'll go to the cardiologist, and then you lose them along the way. The amount of money they spend there. Think of the cost of dialysis, think of a CABG, think of PTC. This is very expensive. But they do not understand, or maybe, I think we also need to understand that if we treat the blood glucose, like you said, 77 rupees, even for that is worth it. If we can prevent or delay a complication as far as possible. So we need to address all these issues. And like I said again, it's country specific, it's individual specific, but you have to hammer, hammer, and hammer.
And we must, sorry, I would like to add something. We must also involve policymaker, government, for make this. It's not only doctor and pharmacists can provide, but it must be government strategy. It's for cost effectiveness, for save money. Yeah, it's like we speak about complication, long-term complication, but also hospitalization after they have this infection disease. This is also big cost. And then we must push also policymaker because the government could be paid for this because save money and understand this cost effectiveness. It will be solve this problem.
Sir,
Thank you. We'll have one last question, please.
Ma'am, my question is to A.K. Azad Khan, sir. Sir, what is the status of supply of insulin to type 1 diabetic kids in Bangladesh who belongs to below poverty line BPL families?
We were able to persuade the government that all type 1 diabetes will get insulin.
Okay, sir, is it given free of cost to them?
Pardon?
Sir, is it given free of cost to all patients?
Yes.
Okay, sir.
Yes. You see, there is one thing I must emphasize, even to my president, that insulin is a human right issue for type 1 diabetic. Cool. Because everybody has the right to have air, water, food. A type 1 diabetic, in addition, needs insulin for survival. So it is a human right issue. And if you take it as a human right issue, then you can ask your government that at least all type 1 diabetics should be given insulin-free, basic insulin-free. Then you see, incidentally, in the subcontinent, let's say, type 1 diabetic are not in large numbers.
Exactly,
They don't
sir.
cost government too much of money.
But still, sir, in India, it is not free of cost.
It is a political decision to be taken. And it is something feasible for any government.
Okay, sir, thank you.
So I just hear that the time is over for this session, and I would like to take the occasion or the chance at the IDF symposium to thank two leaders of diabetes care globally for their presentation. If you forget everything what you have here, but you are here in the room, you listen and you discuss. Insulin is a human right. Take this message home into your environment. This is important. Think about cost efficacy in your environment, how to treat, and vaccinate, vaccinate, vaccinate.
3 cheers for Peter. Hip hip hooray. Okay, now, of course, it's my duty to officially thank Peter, Irina, and Dr. Khan for this wonderful IDF symposium. You're representing IDF, you're representing Southeast Asia, and I think you're in the EMA, isn't it? Which is IDF, okay. All IDF, perfect. And of course, and my co-chair, Dr.
Max Muller didn't ever come to India. but you wrote beautiful description of Rigved, and the Ganges which flows. We come from the Twin City, where there's a Kumbh, Prayag, and Kashi, and he described but Atharvaved from the Ayurveda from there has been described. So it's nice to listen to you, someone from Germany after 200 years back.
Wonderful session. Wonderful.
Thank you to everyone.
Very, very kind.
ये क्यूआर कोड स्कैन करके आपको ऐप डाउनलोड करनी होगी
Okay.
और उस ऐप में आपका सेल्फी लेना है डालना
Oh,
होगा
right, right. You can just
तो आपके
download it
जितने
and
भी
then
फोटो
take your
है
selfie, and then you will have all the photographs that you.
जितने भी फोटो है सब
All the
आप पे आ
photos.
जाएंगे पूरे ऊपर नीचे जहाँ पे भी
So then
जहाँ पे भी
your
होगा
face there, you understanding doesn't happen. Identify your face.
सेशन कौन सा कौन सा वाला?
Very good afternoon, everyone. After a wonderful lunch, may I request you to start with the next session, which is Learning with the Legends. And I would like to invite the chairpersons, Dr. Abhay Sahu, sir, man behind Diabetes India 2024 in Bhubaneswar, Dr. Jamal Ahmed, sir, and Dr. Sanjay Datta, sir, if you're available. Welcome to the stage, sir. The stage is all yours, sir.
Hello, everyone. I'm Sanjay Datta from Breakthrough T1D, a not-for-profit research funding organization focusing on mostly type 1 diabetes, based in New York, but we are an international organization. It's my privilege to co-chair this session with my chairs here next to me, learning from the legends. And may I call the first legend, Dr. Madhu Pandey, to give the opening talk here. Dr. Pandey is an endocrinologist here. She's a senior consultant there from Nepal, and she has had many hats here. She's also an executive member of the Dean, and published significantly in the area of thyroid metabolism, CD40, CT1 interaction, and so on and so forth. Today, the title of our presentation is NAFLD and CV risk. So, Dr. Pandey.
Thank you, Chairperson, and thank you, Diabetes India, especially Dr. Bansi Sahu and Dr. Amit Gupta for inviting me here. And so I will say this is the out-of-the-box topic here, because this is totally a metabolic sessions here going to be held again here. So beginning with the NAFLD and CV risk. So may I continue? So we are going to discuss the physiological changes in the cardiovascular system in the patient with NAFLD, describe the cardiovascular outcome, and evaluate the approaches to target cardiovascular risk in NAFLD trials, incorporate the CVD risk and risk reduction strategies. So we have the terminology now understanding the liver health. NAFLD is also known as MASHLD, non-alcoholic fatty liver disease, metabolic dysfunction associated with fatty liver disease. NAFLD affects around 30% of the world populations and is the hepatocellular part of the spectrum of metabolic syndrome, which compromises the obesity, atherogenic dyslipidemia, peripheral insulin resistance, type 2 diabetes, and hypertension. As a global prevalence of obesity and type 2 diabetes is on steady rise, NAFLD is regarded as a major public issue. NAFLD involves the atherogenic dyslipidemia, significant risk factor for cardiovascular disease, which is the leading cause of death in patients with NAFLD. Talking about the epidemiology, with the global prevalence of the NAFLD is a chronic liver disease affecting 30% of the global populations. And the prevalence rate of NAFLD and NASH among type 2 diabetes patients is 54% and 62.26% respectively. The rate of disease progressions are associated with age, ethnicity, genetics, and presence of comorbidities such as obesity, type 2 diabetes, and hypertension. The presence of dyslipidemia, hypercholesterolemia, triglyceridemia, or both has been reported as 20 to 80% of the cases associated with NAFLD. Prevalence of coronary vascular disease is 26% and cerebral vascular disease 20%, and peripheral vascular disease is 15.4% with these studies. The prevalence of NAFL general populations is 9 to 53% in Indian scenario, with the regional wise rural area has West Bengal 8.7%, coastal south 49.8%, which is the highest, and even the North India has the highest prevalence of NAFLD with a 53.7%. NAFLD in high risk Indian adults with obesity is 52.8% in type 2 diabetes. The prevalence of non-alcoholic fatty liver disease, we can find out only one studies in Nepal that was done in Kathmandu patient. So it was 49.4% of the patient have NAFLD. Type 2 diabetes population with dyslipidemia have 38% higher risk of NAFLD. So talking about the pathogenesis and progressions of disease, we have the non-modifiable factors and modifiable factors. So the modifiable factors that we have: gut polymorphism, genetic polymorphism, gut microbiome, and environmental and social factors, dietary saturated fat or PUFA. So when the energy intake exceeds metabolic needs, because of the high intake of fructose, glucose, and sucrose, hepatic de novo genesis lipogenesis starts, which will increase the triglyceride level, deposition in the fat, deposition in the liver, which will lead to elevated cholesterol level and triglyceride, which will increase the risk of CVD. And further, if the free fatty acid deposition is there, oxidative stress, ER stress, and inflammation activation is there, which leads to phenotypes of NASH, fibrinogenesis, leading to fibrosis, and genomic of DNA damage, leading to hepatocellular carcinoma. And free fatty acids that will do the mitochondrial beta oxidations, leading to disease progressions. Risk factor for NAFLD and NASH, we have type 2 diabetes, that is insulin resistance, prediabetes, obesity, metabolic syndrome, elevated liver enzymes of greater than 6 months, and family history of cirrhosis. So how to detect this hepatic NAFLD, hepatic steatosis in adults? We have lean obesity in our Asian population. So we want to talk about the obesity or overweight as defined as BMI greater than 25 in Caucasian and BMI in greater than 23 in Asians. They are known as metabolic dysfunction associated with fatty liver disease. But in the lean normal weight patient, when the BMI is less than 25 in Caucasian and BMI is less than 23% in Asians, in that scenario, we need at least 2 metabolic risk factors. So that is waist circumference greater than 102/88 in Caucasian male and female, and blood pressure of 130/85, triglyceride level greater than 150, and pre-diabetes level 100 to 125 in the fasting, and PP sugar 140 to 199, high level of CRP level, homeostasis model assessment insulin resistance score greater than 2.5. So we are linked with the diabetes, NAFLD and diabetes. So talking about the NAFLD and type 2 diabetes, when the hepatocytes increase mitochondrial beta oxidation leads to FFA, that will lipid overload with further impair the mitochondria antioxidant capacity, leading to oxidative stress and mitochondrial leakage, aggravate the insulin resistance. And leading a link between the NAFLD and diabetes, when we have type 2 diabetes that is linked to NAFLD. In patients with type 2 diabetes, liver lipogenesis is elevated with hepatic uptake of fatty acids upregulated under the insulin resistance status, and with the excessive hepatic FFA influx in type 2 diabetes patients such as palmitic acid, cholesterol, lysophosphatidylcholine, and ceramides that will directly cause lipotoxicity and induce liver inflammations and fibrosis. NAFLD often coexist with type 2 diabetes. So there is a link between NAFLD and diabetes. We can see this slide. NAFLD leading to type 2 diabetes because of hepatic insulin resistance, glucose production increases, protein kinase increases, futin and RBP4 increases. And if the patient has the NAFLD, that will increase the triglyceride levels and lipid toxins that will lead to atherosclerotic diabetic nephropathy and diabetic retinopathy. And with the circulating free fatty acids and adiponectin and peripheral insulin resistance, that will again lead to fatty liver disease. So with all these things, NAFLD and and diabetes are interlinked with each other. Link between NAFLD and CV risk at early stage NAFLD can increase the cardiovascular risk. Special group patient with NASH and advanced fibrosis with F3 and F4, patient with concomitant type 2 diabetes, patient who have high risk of cardiovascular events and mortality, and current evidence suggests NAFLD increases the risk of developing CVD, experiencing cardiovascular events. The overall cardiovascular risk results from the combination of NAFLD stays and other cardiometabolic factors. So NAFLD is also associated with insulin resistance, leading to resistance in the anti-lipolytic effect of insulin in the adipose tissue with the increase of free fatty acids. So when the triglyceride production increases, that will stimulate the secretion of VLDL in hepatocytes, leading to oxidative stress and lipid perioxidations, increasing the secretion of inflammatory markers, plasma glucose and HDL concentration will decrease. That will be linked with the increased risk of cardiovascular risk. So we have the complications, NAFLD related to cardiac complications like coronary artery disease, cardiac dysfunctions, coronary cardiac hypertrophy, heart failure, valvular disease, mitral anal calcifications, atrial fibrillation, and QTc prolongations. NAFLD is strongly related with the features of metabolic syndrome, that is insulin-resistant metabolic syndrome, dyslipidemia, hypertension, leading to the cardiovascular and cerebrovascular disease. So we have the two-hit hypothesis about the NAFLD progressions and complication. When we have the normal liver disease, most NAFLD exhibit benign simple state of cis-progrossis. 10% have the NASH with hepatocyte injury and inflammations. Approximately 20% of patients with NASH with advanced NAFLD fibrosis scoring F3 or compensated cirrhosis will progress to cirrhosis. Patients with NASH are at risk of developing hepatocellular carcinoma in the absence of cirrhosis. So there is always sedentary lifestyle, high fat intake, insulin resistance, and obesity that will lead to simple steatosis, which can be cured with the lifestyle management. But when the NAFLD reaches to MASH, it's very difficult to cure it. So we have the other complications: arthrogenic dyslipidemia, chronic kidney disease, osteoporosis, heart failure, sleep apnea, polycystic ovarian syndrome, malignancy. So how to diagnose this NASH? So we have the ultrasound, non-invasive score like APRI, FibroScan, NFS, and FibroScan, liver biopsy, and liver enzymes, lipid profile, and glycemic parameters. The management of NAFLD involves lifestyle modifications, pharmacological therapy, surgical approach. So lifestyle modification is the management relies in lifestyle changes. So including the diet and exercise, if we aim for the weight loss of 7 to 15%, we can risk the reduction of the NASH, simultaneously assess and treat the cardiovascular risk together. Surgical approach: in every obese patient, bariatric surgery is the primary treatment for weight loss, effectively improving or resolving the obesity-related metabolic complications. So exercise without weight loss produces 20 to 30% of relative reduction of steatosis. Different form of exercise with high intensity, intermittent aerobic exercise appear to have similar effects. Diet, especially the Mediterranean diet, works both for NAFLD and CV, more with dietary fibers, plant-based protein, unrefined grains, fish with omega fatty acids, legumes, and nuts. And we have the treatment options of pharmacological therapy. Therapeutic options for NAFLD and NAS. We have the statins for decreasing the cholesterol level in our body, and we have the mitochondrial beta oxidation can be reduced by the dual PPARY. agonist, that is saroglitazar, which has been talked by Dr. Bhattacharya and others. And we can decrease the PPAR by agonist pioglitazone, which can decrease the adipose tissue of fat storage capacity of liver by pioglitazone. We have the GLP-1 agonist that is also very useful. So first treatment option for NAFLD complications is complicated by CVD, lifestyle, physical activity, weight loss, energy restrictions, smoking cessations, and optimal medical therapy that we have for the CVD is aspirin, anti-diabetic medications, anti-hyperglycemic agents, and lipid-lowering agents, and bariatric surgery. So we can see some of the studies that has shown pioglitazone meta-analysis has shown greater efficacy in reducing ALT and AST compared to other drugs, and significantly improves the HDL and had little effect on reducing the LDL level. And statins prospective intention to treat studies has shown significantly decrease VLDL and LDL and increase the HDL, improves liver test and reduce cardiovascular morbidity in NAFLD patient. Fenofibrates significantly reduces the triglycerides and LDL and has beneficial effects on treatment of fatty liver. And vitamin E significant has prospective and comparative observational studies with a vitamin E 800 mg has showed significant reduction in SGPT, SGOT, and triglyceride from baseline. So we have many drugs underlying. So we have pioglitazone, rosiglitazone, lansif, and saroglitazone, PPARY. We have got microbiota dysbiogenesis with solely thromycin. We have the GLP-1 agonist with liraglutide and semaglutide, tirzepatide, and we have the SLT inhibitors, canagliflozin, dapagliflozin, empagliflozin, and other drugs like pentoxifylline and FXR. They all are on the queue of trials, and many research are to be made there. Vitamin E is still not recommended in type 2 diabetes, but we can practice that in our only NAFLD patient with without diabetes, only in patient with proven biopsy, NASH without diabetes actually. Long-term use increase the risk of prostate cancer and hemorrhagic stroke, and thiazolidinones have the associated with weight loss, peripheral edema, increased risk of heart failure and bladder cancer. So we should be cautious about using the pioglitazone in our patient with NAFLD and type 2 diabetes. And it is associated with osteoporosis in menopausal females. So in that scenario also, we need to be more cautious about it. So limitations of existing therapies. So fenofibrates with a low potency, limited selectivity of PPRA, associated with increased risk of myopathy, cholelithiasis, vein thrombosis, decline in renal functions, and elevated transaminase. Studies with fibrates in NASH has no significant improvement in steatosis or fibrosis. Statin does improve lipid profile, but not beneficial on liver biopsy, liver histology in patient with NASH. So therapeutic options for NAFLD with comorbidities NASH include PPRS, nuclear receptor, regulating metabolism, inflammation, growth, and differentiation. Glitazar we have now, sologlitazar acting on PPARA and PPARY, tackled by NAFLD issues, dyslipidemia and insulin resistance. Development of tesaglitazar, muraglitazar, and aliglitazar for DD treatment for was halted due to because of adverse effect linked to significant Y actions. And saroglitazar with predominant PPRA effect on moderate PPRY effects lacks the side effects. So still saroglitazar is preferred choice for the NAFLD with comorbidities and cardiovascular risk. Thank you so much.
Thank you, Dr. Madhu. You can take your seat. We'll have a discussion at the end. So our next topic is CRM syndrome revisited. For this topic, I request the speaker, Dr. Messiha Kamal from Egypt. Yeah. So, noise. Change this.
It's the previous way, not this one.
So go to the slides. The past page of the slide will be.
Bismillah ar-Rahman ar-Rahim. Good afternoon all. Thank you, Mr. Chair. Thank you for the Diabetes India organizing committee. Thank you for Banshi and all the team. And special thanks that this session is addressed under the Diabetes in Asia Study Group, being the immediate past president of Diabetes in Asia Study Group. I am proud to share in this session and participate. And the previous talk facilitate my mission because we are now talking about the cardiorenal metabolic syndrome, and this is my disclosure, and this is the references if you want. And why we are talking about cardiorenal metabolic syndrome? Why is this term now? Because there is a high prevalence of this constellation of affection of metabolism and linked to the cardiovascular and the kidney, and affecting at last the quality of life of our patient. So we need to think outside the box, because there is growing interest. Now we see many medications can facilitate the mission, but first we can realize that whatever the starting point, whatever, if it is in the metabolism, type 2 diabetes, obesity, or it is in the cardiovascular, or it is in the kidney, always not go to Rome, but go to the constellation of cardiorenal metabolic syndrome affecting our patient. So we see that every detailed item must be addressed in our patient book, and this high prevalence and increased mortality and morbidity and reduced survival. Look for this. If diabetes alone, we lost about 13 to 14 years with earlier onset of diabetic complications. If diabetes and the chronic kidney disease combination, we see the mortality to be 31%, mostly 3 times any one of them alone. And this reduced survival and reduced also quality of life, making us must look in depth for the pathophysiology of the cardiorenal metabolic system interconnected, and whatever the starting point, it will force the sequence to develop the others. But noting this slide is very important, because staging of cardiorenal metabolic syndrome now starting from 0, not from 1. And also the prevention must starting at this point. So stage 0, we have nothing. We have no risk factors, but we want to prevent this risk factor, because adiposity is there. And the adiposity is the key. All of the speakers today and yesterday and tomorrow also, and whatever the topic, they said that adiposity and the obesity is the most prominent thing that can lead to the diverse quality of life and the morbidity and mortality. So stage 0, we have no risk factors. Stage 1, we have starting exists ectopic adipose tissue. Whenever this adipose tissue is located ectopically, either pancreatic or in the liver, like the previous presentation, or in the epicardium, or anywhere, it floods the circulation with inflammatory mediators and causing histological and functional alterations that lead to target organ damage. Stage 2, we have the metabolic risk factors, dyslipidemia, especially triglyceride, hypertension, diabetes, and all the aspects of metabolic syndrome. And if we have also chronic kidney disease, neither due to hypertension nor due to other risk factors, but only metabolic. Stage 3, we have the subclinical cardiovascular disease. We have the renal affection. We have a very high risk patient to go on the other way of cardiovascular and renal affection. Stage 4, we have the clinical overt cardiorenal metabolic syndrome. The value of this staging, not only to know where we are and how to stratify our patient according to the stage, but also these stages are interchangeable. Think that if we are starting early in stage 1 or stage 2, we can stop going to stage 3 and stage 4. And this is a very important issue, that early, effective, holistic approach must replace the fragmentation of care. Here is the fragmentation. All the time, we were said that to control diabetic complication, you have the ABCs. You have the lipids, diabetes, and cardiovascular. But now we have all this constellation together. We need the hepatologist, the cardiologist, the nephrologist, the dietitian, with management, all in one. So all in one can be translated clinically to team approach, and this is must replace the fragmented approach that take only one entity. Debates that glycemic control may decrease the complications or not, dyslipidemia or also. So these debates must be going on, and we must concentrate on the holistic approach. We must address all the areas. So this rationale of staging, that we can know where our patient is, and also we can know whatever the modalities that can address the current status of our patient to prevent progression and sequential decline of the target organs in this modality. So screening of cardiorenal metabolic syndrome is very important. But here also, I remind you that biological screening or traditional screening, including body mass index, waist circumference, and the components of metabolic syndrome, and the muscle and renal functions, and all the labs are not enough. We are now must looking for what is called social determinant of health. In our communities, especially low and middle income communities, we must address this: food security, housing instability, finance, access to care, transportation challenges, employment, health literacy, social isolation. All these must be screened in every patient. So, not to go to prescribe your patient a medicine that can not be affordable to him. Not to go to advise your patient against his social context. But you must know this. So this is modality of screening must be in mind. And according to the stage, we can screen annually for stage 2 if we have remember that stage 2 have the starting of the adiposity or for CKD 2 to 3 years for stage 1, 3 to 5 years for stage 0. Stage 0. Remember, stage 0 have no risk factors, but we want them not to go to this cardiorenal metabolic club. To prevent them from entering this club, you must do this first. So, starting early life, as you see, the traditional before we are starting to investigate our type 1 diabetes after 5 years and type 2 diabetes when diagnosed. No, if the patient is at risk, we can start so early at the age of 3 years or 9 years. So everything is changing now. It is your patient that dictate what you will investigate and what you will screen for and how to stratify him. And again, the social determinant of health, as I said before. So we need risk prediction, whom we will screen, because as all of you know that there is no universal screening can be accepted neither on the context of science or social or finance. So one of unmet needs remains that we don't have prediction or predictor algorithm that who will be screened, except sometimes they said about the renal functions or the social context or the obesity or familial dyslipidemia. But still, up till now, we have no Framingham score, we have no score 2D, we have no like this. So risk prediction remains a challenge. And as I said before, this approach to the cardiorenal metabolic syndrome, instead of being fragmented care, we must have coordinated care. And according to the stage, if we are starting from stage 0, our intention is to increase exercise, leave away the sedentary life, and preventing weight gain. And the obesity prevention is the first one priority. And here you start early, even for the maternal health, because when you are caring for the mother, the offspring will come also in a good health and away of the risk factors. So you must start as early as possible. Stage 1 excess of dysfunctional adiposity, also decreased weight, lifestyle changes. Sometimes lifestyle changes cannot be as effective as we want all, but don't neglect it. But put it and put on the table also the pharmacological approach. Especially we have now weight management drugs like GLP-1s and SGLT2, and we can go forward for this even If it is necessary, you go to the bariatric surgery. But don't leave your patient even in stage 1. And in stage 2, you must address the established risk factors like weight, like hypertriglyceridemia, hypertension, chronic kidney disease, using all the weapons, either pharmacological or non-pharmacological. And this must go to the goal that you prevent your patient from going to the stage 3. Stage 3 is a subclinical, and the subclinical we have tools, especially coronary artery calcium can be valuable at this stage, and we can define the stage of heart failure subclinically before it goes, and also the risk for chronic kidney disease, and we can manage accordingly. If these stages went away from your hands and you are faced with your patient with stage 4, that you already have cardiovascular disease and chronic and without chronic kidney failure, the goal of management is to optimize the care for secondary prevention for your patient for CVD and prevent the progress to the failures, either heart failure or kidney failure. And in all of these patients, the pillars, all we are known. We can use all our weapons like beta blockers, angiotensin receptors, neprilysin inhibitor, mineralocorticoid receptor antagonist, and the SGLT2 inhibitors in patients, especially if there is heart failure, even with reserved or reduced ejection fraction. So GLP-1 and SGLT2 are markers. Here are our weapons. Look for every one of these modalities can do more than one job. And I think the question mark about tirzepatide in chronic kidney disease are now cleared by the recent research that they are good for keeping the patient away from progression of kidney failure. But SGLT2 have metabolic, cardiovascular, and renal targets, and GLP-1 also, and mineralocorticoid receptor antagonist, and tirzepatide, as I said. In diabetes management, the priority to these drugs that can prevent progression of cardiorenal metabolic, the protection of the target organs from damage, and also lead to glycemic control. But if you are faced by a progressive stage of chronic kidney disease, SGLT2 inhibitors here to delay the regression, the progression of glomerular filtration rate, but make another anti-hyperglycemic adding to this because glycemia will not be controlled. So interdisciplinary care is most important, and my message that education is very important. And here we are developed in MENA region, IDF, an educational program for cardiorenal metabolic disease, and this will include the 7 modules in agreement with the diabetes school of IDF, diabetes school, and will be propagated soonly, launched at the next quarter of 2025. My take-home message, Mr. Chairperson, cardiorenal metabolic disease now have very succeeding prevalence, and we need holistic approach to entail every detail in this syndrome. and we must consider the social determinant of health when screening and when treating and when facing our patients, and the availability of effective approach address depository and the pharmacological and bariatric surgery are there. And thank you very much.
Thank you, Dr. Mesbah Kamal, for a beautiful and talk. We'll have a discussion after the end of the session. So for the last session of this topic, this session, last topic is gestational diabetes. What are the challenges in management and what are the alternatives to insulin? For this topic, we have with us Dr. Anuj Maheshwari. He's my elder brother. He's everybody knows him, and I don't require any introduction. And Anuj sir for this topic.
Thank you, Chairperson. Thank you, Abhay, for the kind introduction. This topic was supposed to be taken by Dr. Nadima from Jordan, but she could not make it, so that's why I am filling the gap. So I shall be telling you about the gestational diabetes, challenges in management, what could be the alternative to the insulin. Because insulin therapy also remains the challenges in the treatment of the gestational diabetes. Manifestation of the glucose intolerance in pregnancy, often named as the gestational diabetes mellitus, is emerging as a major public health problem, not only in India but across the world. IDF 2021 say that global pooled prevalence of gestational diabetes is estimated to be 14%. In the Southeast Asia, IDF reports that 1 in 4 live births is affected by the hyperglycemia in pregnancy. A systematic review and meta-analysis estimated the pooled prevalence of the GDM in India to be 13%, although it is quite variable when we move from north to south, starting from the 4% in J&K and 16 to 18% in Tamil Nadu. So when we talk about the gestational diabetes or hyperglycemia in pregnancy, the things arising in the same fashion as it remains, it is out of the pregnancy. Insulin resistance is a need of the pregnancy. Insulin resistance is a thing which is welcome in the pregnancy. For that, it is a mother is able to make the child's body get the fat deposition on the fetus, and this helps in developing the fetus. But once it becomes too much high, that maternal pancreas is not able to handle the challenge of the insulin resistance, it converts into the hyperglycemia in pregnancy. And when it happens, it is also associated in the adipose tissue dysfunction, gut dysbiosis, liver dysfunction, skeletal muscle dysfunction, what the things are usually seen when insulin resistance is rising out of the pregnancy. And this hyperglycemia in pregnancy is responsible for maternal and fetal complications. Not only the complications, but also we can see the next generation risk for the type 2 diabetes. When we talk about the risk factor which may be posing a larger challenges in patients with the gestational diabetes, of course, that could be the family history of diabetes, previous gestational diabetes history, multiparity, high blood pressure, advanced maternal age, overweight, obesity, PCOS, ethnicity, especially the Asian ethnicity, previously macrosomic baby, which have been having the weight of more than 4.5 kg. So what is the biggest challenge while managing the pregnancy? St. Vincent Declaration says that achieve a pregnancy outcome in a diabetic woman that approximates that of the non-diabetic women. And this is the biggest challenge in the given condition when we really need to have a baby of the optimum weight between 2.5 to 3.5 kg, which may not get any complications in the future life. So managing GDM not only saves 2 lives, but also it is important primary prevention of type 2 diabetes in next generation. It helps in identifying mothers, those who are more vulnerable to become the type 2 diabetes in their future life. And of course, it reduces the occurrence of type 2 diabetes in generation to come. So this is the biggest advantage of treatment of the gestational diabetes if we can really do that. What could be the target blood glucose levels? Of course, the fasting level should be 90 milligram or less than that. Postprandial level should be less than 120 milligram. Mean plasma glucose level should be around 105 milligram per deciliter. And if it can be managed, then we can expect a mother is delivering a child between 2.5 to 3.5 kg, which could be a step to prevent the offspring which may not develop the type 2 diabetes in the future life if her birth weight will not be less than 2.5 or more than 3.5. What we could see that hyperglycemia brings preterm delivery. Even the percentage of the preterm delivery increases with the increasing hyperglycemia as the pregnancy duration increases. ADA 2018 has recommended that HbA1c target in pregnancy 6 to 6.5%, but if it could be managed less than 6%, it may be optimal if without significant hypoglycemia, but relaxed to up to 7 if necessary to prevent hypoglycemia. So this is the HbA1c target less than 6, but even at 5.5, we can say some sort of the preterm delivery could be seen. Glycemic targets in women with diabetes are really a challenge because we need to manage the fasting glucose less than 95 and 2 hours postprandial less than 120. With multiple organizations are saying little bit different, but more or less the targets they are having a consensus of this sort. So glycemic control should be assessed every 2 weeks at the diabetes clinic whenever a person, a lady is in the pregnancy. Hyperglycemia at the conception is also associated with risk of congenital malformation. And this is another challenge. And this actually gives an insight us that we should do the screening of every mother who is going to be pregnant. So pre-pregnancy screening of every mother, whether she is diabetic or non-diabetic, is most needed. Unplanned pregnancy should be discouraged, and many a times it happens because of lack of awareness. Women and their family members don't know the consequences of the gestational diabetes, and they enter into the pregnancy without knowing the status of their insulin resistance, without knowing the status of their glucose intolerance, and many a times maybe obesity, which may lead to the insulin resistance rising very fast, may not be handled well by the maternal pancreas. So limited knowledge about the self-monitoring of the blood glucose, dietary control, physical activity, lack of education regarding the postpartum screening. So a lot of things are there which may be the challenges as far as the self-management of the pregnancy with diabetes is concerned. A lot of myths and taboos are also responsible for this mismanagement, like some people believe that exercise may be the harmful during the pregnancy. Pregnant women should be eating for 2%. This is a common misnomer and common myth among many families that if a lady becomes pregnant, she should double his food. Family fear that taking insulin is another myth which many people think that if we shall be injecting the insulin in the abdomen, it may harm the existing fetus. So family influence often overrides the medical advice, leading to non-adherence to the diet and treatment plans. Poor compliance with the lifestyle modification. Financial constraint many of the time is also responsible for the adhering to the management strategies what are advised. Many of the times in rural areas, women have to travel long distance for GDM screening and care. And because of the limited availability of the trained phlebotomist and standardized laboratories, many a times it may not be possible to take the fasting and PP board. In such condition, the DIPSI has suggested that if we can take a single step procedure in antenatal clinic, a pregnant woman is given 75 gram oral glucose load, irrespective of whether she is in the fasting or non-fasting, without regards to the time of the last meal. GDM could be diagnosed if the 2 hours plasma glucose is equivalent of more than 140 milligram per deciliter. At the healthcare provider level, what could be the challenges? Of course, multiple guidelines creates a lot of confusion among the healthcare professionals, and they are not really having their mind made up what to treat and what level should be targeted and how to treat. Universal screening is not widely implemented most of the time, and many pregnant women are not tested at early enough. Lack of the training for the healthcare providers may also be responsible for not diagnosing the GDM at appropriate time. Poor coordination among the doctor and patient may also be responsible for the poor follow-up and not appropriate postpartum care. And many of the time, patient may not be compliant to the advice what is being given by the healthcare professional. Need for a multidisciplinary approach is very much needed, but sometimes our system is not so much aligned that obstetrician, diabetologist, and nutritionist and primary healthcare worker may come in the close coordination. Many of the time, there is no standardized referral system, which is resulting into the fragmented care. So recommendations to address the challenges, how can we really address these challenges? Of course, we can conduct a public health campaign to educate women about the GDM. We can ensure that all pregnant women should be screened. Universal screening should be tightly implemented. Standardized guidelines must be there. There may not be any confusion among the healthcare professionals. We should have the training program for the healthcare professionals, integrate the GDM management into the existing maternal health programs and provide free for subsidized glucose testing and insulin. And of course, the establishing the routine postpartum screening program to prevent the progression to type 2 diabetes, which is the most important. So why screen if we cannot follow up and manage? Then this follow up and management remains the problem in the developing countries, especially like India. Many of the times, the developed country in the Asia like Singapore, there are the barriers to gestational diabetes management and preferred interventions for the women with GDM when working women are reported to have the barriers to the GDM management when they do not have the reminders for the blood glucose monitoring. They may not be having the appropriate reminders for the diet control, insufficient time for the exercise, and so many other excuses remains there. 80 to 90% women with GDM could be managed effectively by the medical nutrition therapy, in which we can give the appropriate diet plan and exercise to handle it GDM without any help of the pharmacological intervention. Women with normal BMI should have the recommended weight gain to 11.4 to 15.9. Who are overweight, they should be allowed to gain the weight 6.8 to 11.4, and obese women should not gain weight more than 7 kg. For women at high risk of the excessive weight gain, intervention need to begin in the first trimester. Weight gained in the first trimester is more predictive of the infant weight than the weight gained in the third trimester. So if weight gain in the first trimester is more, we are having the enough opportunity to stop it so that the fetus may not become the macrosomic. No increase in the calories in the first trimester is advised, so we should not follow the pregnant women should eat the double or eat for the two. An additional 340 kilocalorie during the second trimester can be added and 452 calories during the third trimester could be added. Recommendations for the treatment of the GDM, most women can manage the GDM with the lifestyle intervention, I say 80 to 90%. But if it is not, but after the 2 weeks of the trial of the medical nutrition therapy, it is mandatory to either start on the insulin or go for the oral hypoglycemic agent. Now question arises, insulin always remains a challenge most of the time. What could be the replacement of the insulin? Do we really go with some oral hypoglycemic agents safely? Of course, the metformin have been found to be very much useful and benign as compared to the other oral agents if the insulin is not the option or the insulin is not accepted by the patient. It improves the insulin sensitivity, has the lower risk of the maternal weight gain, hypoglycemia. But one thing we should not forget always, that insulin resistance is the basis or physiological need of the pregnancy. Metformin reduces the insulin resistance. We should always be careful that it may lead to the low birth weight, it may lead to the failure of thrive to the developing fetus. So when we talk about the metformin, it could be effective in preventing adverse perinatal outcomes, may even have possible benefits in the long term. A lot of randomized trials has supported that metformin could be useful, and when the metformin has been added up to the treatment, it has been found the probability of the insulin initiation could be lesser than as compared to the placebo. A meta-analysis of the metformin and insulin has proven that metformin demonstrated a significant reduction in the risk of the preeclampsia, induction of the labor, cesarean delivery, macrosomia, neonatal intensive care unit, and admission to the ICU and neonatal hypoglycemia. Alternatives to the insulin, another alternative could be the glyburide. A lot of trials has been done, but not in India. Most of the studies are from the Israel and other parts of the world. Langer has done a lot of studies about the glyburide. It does not cross or crosses very little to the placenta. Metformin crosses the placenta. This is the difference between these two molecules. So if we talk about the oral hypoglycemic glibenclamide, the use of the oral glibenclamide for the treatment of the GDM is alternative to the insulin therapy because of the similar glycemic control, ease of administration, and better patient compliance. But hyperinsulinemia is a thing which arises because of its use, this particular sulfonylurea, and many a times it becomes the reason of the abortion. Another alternative, the acarbose, which could be tried. A lot of people have started, but no recommendations are available by any authority, and we do not have the randomized control trial for the acarbose. So limited evidences are there, but it is effective in mild GDM because postprandial hyperglycemia is the problem with the GDM, so it could be corrected with the acarbose. It causes some GI effects like bloating and diarrhea, and safety data are not available. So as far as the recommendation is concerned, insulin, of course, the first recommendation followed by the metformin and glyburide could be chosen, but acarbose is having very little data. So take home message, GDM poses a significant risk to both mother and fetus, including macrosomia, preeclampsia, and neonatal hypoglycemia. Early diagnosis and intervention through medical nutrition therapy, lifestyle modification, pharmacotherapy are crucial for improving maternal and fetal outcome. Insulin remains the gold standard for pharmacological management, providing tight glycemic control without crossing the placenta. While metformin crosses the placenta, glyburide also crosses the placenta, but lesser than the metformin, having the convenience and affordability among the population, but their use should be individualized due to the concern over the placental transfer and neonatal effect. Postpartum follow-up is essential as 50% of the women with gestational diabetes develop type 2 diabetes in their later life within 5 to 10 years. Long-term maternal and fetal monitoring is key to preventing future metabolic disorder. Thank you very much for your kind listening.
Yeah, thank you, Dr. Anush, for a lucid and well illustrated topic. And requesting all previous speakers, Dr. Nesma, Dr. Madhu, please come to the stage. Any questions from audience? Anything? And before that,
Well, as you all are thinking about your questions, I'll get started here. I'll go to Dr. Pandey first. Dr. Pandey, given the large number of trials that are ongoing with SGLTs, GLP-1s, very large, tens of thousands of patients, have you approached any of the companies to see if there was a subgroup of patients with NASH or NAFLD in them, and see if there was any evidence? It wasn't powered for that, but have you looked into some subcategories in those studies? Because these are all comorbidities that often co-segregate.
Such a nice question, sir. Actually, in our practice, I'm a endocrinologist. I only do the clinical things. So I come across the patient with NAFLD or NASH or MESILD. So they go to the hepatologist and they do the fibroscan and everything. And some hepatologists do recommend GLP-1 agonist. And for that patient, I have seen significant changes with fibroscan score and all that. I have seen in my patient with diabetes and with the coronary vascular disease also. So I have seen lots of significant changes.
But you can probably...
Yeah, there is a dedicated trial with semaglutide with NAFLD. Can you put some light on that?
So semaglutide is not so much available in Nepal, sir.
Yeah. There is a dedicated trial going on which includes directly biopsy probe, the liver biopsy. That is the beauty, because what they found, the interim result is showing there is a reversal of fibrosis with use of semaglutide. So that is again one of the upcoming thing which will come probably this year. We'll get the full result. It already has been published partly, but we'll get the full result. But still, there is a reversal of fibrosis with oral semaglutide. Of course, SGLT2 data is showing there is reduction in fat, but they usually don't have any effect on the fibrosis point of view. Again, saroglitazar has clearly shown, as you have shown, but still not it is approved for muscle. There is indication, but still it is not US FDA approved still. And there is only one drug which is approved for particular muscle. This is, can you put some light? Resmetirom, no, that's
No much shade. Here, Nepal?
no.
No.
One word. This is US
So worldwide for, I think it's SLT inhibitors are approved. No?
This resmetirom is the drug.
Yeah, Resmetirom is a new drug that's been approved right now.
This is the only drug.
So
This is the only.
no idea.
The only US FDA approved drug for muscle is resmetirom now. No other drugs actually. They have Sarabutazer actually has put their file, but still it is not yet approved for the US FDA. And of course, now GLP-1 has actually very promising result. Probably within next 2 years, we'll get approval for that. And again, the only approved drug now is not vitamin E. Of course, pioglitazone has shown some role, but again, it's not approved. The only approved drug is resmetirom is the only drug which is approved for particularly muscle. Yeah. And sir, CKM, we know that CKM is one of the most burning topic now coming up. So could you put light that now actually this concept of CKM has come now, there is upstream management of diabetes instead of downstream. That means what we used to do initially, we take glucose and wait till when the complication happens. Now the focus is to start upstream, that you treat obesity, you treat all those things to prevent the diabetes, you prevent the complications. What is your thought on that?
Yes, the recent staging of CKM or CRM rationality lies here that starting from stage 0, you must prevent the adiposity. And I think this morning Shashan outlined very elegant term of adiposity. Adiposity means the ectopic adipose tissue anywhere. You must prevent this. So staging now have the rationality to stop at stage 0, not to go to the even primary or secondary intervention. And this may shed the light that weight management, and I think your question for semaglutide may be some of the lucent aspects of semaglutide in NASH due to weight management also. But maybe I think I am not saying that's the mechanism. But weight management now is one of the central approach. Even here in South Asia, this subject is very important because it is not the matter of body mass index. We found the lean patients with adipose, visceral adipose or ectopic adipose in the target organs, and this is a problem. So now we must concentrate on this.
Any other questions from the audience?
One comment also.
I'm sorry, I was late, my flight was late. So,
yeah, Dr.
when you talk about the...
In your talk, you said that the
Excuse me, excuse me.
Just one second, just one second, let me finish.
I think when you talk about the management of type 2 diabetes, when you talk about typical care or CRF, whatever you call it, the focus is on two parts. One is glycemic management, and the other is the management of comorbid conditions, starting from adiposity, the cardiovascular disease, chronic kidney disease, and also the NASH. We have got some emerging data about SGLT2 inhibitors on adiposity, Phe score improvement, reduction in hepatic cell fat. We don't have biopsy-proof data of SGLT2 inhibitor, but they are encouraging. We have got evidence for improvement in the beta cell functions in terms of improvement in the C-peptide by SGLT2 inhibitors, reduction in the fasting insulin, and improvement in the insulin resistance. That data we are encouraging. Semaglutide, there are some early evidences, but obviously indirectly it is helping by reduction in the weight. That is probably one of the key factors in the pathogenesis of type 2 diabetes. We talk about basically hepatic disease. If you don't manage hepatic disease, probably you are missing the management of type 2 diabetes. So some of these data are encouraging. The other data that have come out with the SGLT inhibitor, particularly with empagliflozin, by reduction in the 38% cardiovascular death and reduction in the mortality, not with the other SGLT inhibitors, you are adding 4.5 years life to that particular person. Same way, we have got also data on SGLT inhibitors by postponing kidney disease or CKD or by reducing albuminuria, we are adding another 5 or 10 years life to that particular person. So I heard your last point in the slide, as you said that the focus is early intervention. And early intervention means you have to not only take care of the glycemic management, but look for all the comorbid conditions which are associated with pathogenesis of type 2 diabetes. Thank you very much.
Totally agree.
Yeah, Dr. Madhu, you said in your talk that the vitamin E is not indicated in a patient with diabetes in NASH. Why?
No, actually, there is one studies which shows that it should not be given to the patient with type 2 diabetes unless biopsy proven NASH. And so I think it's...
Vitamin E has shown some role, but the thing is that always it is given for a short term, usually 2 to 3 months. When you are giving no, there is chance of bleeding is high, there is a chance of, there are some complications. So it is usually for given for 2 to 3 months, not much. So that is the thing.
Antioxidant maybe that will
So this is the reason why vitamin E is not a good thing for particularly management of MSLT specifically. Yeah. So Dr. Anush was, we have a lot of regulations, law, but particularly see for the GDM management point of view, we have data that metformin and glyburide can be used, but looking at our law regulations, what is your thought giving a person glyburide to a GDM patient?
You are very correct, and in fact, in person, I am also the person who believes that insulin should be given in the pregnancy. But as the topic was given, alternative to insulin, and we have to find the alternative to insulin. And whenever it comes for the challenges among the gestational diabetes, top of every challenge, biggest challenge is the injection of insulin. Because of what many patients do not take their treatment, they lost their fetus, they have developed some problems in their pregnancy. So because of what we need to find the alternative, and whatever the alternatives are available, we have got one of the biggest MIC trial. And you are very correct, and I always tell in the personal discussion that Indians' BMI is not matching the population which have been included in the MIC trial. In the MIC trial, both the segment or both the side, whether the insulin side or metformin side, they were having the BMI 34 to 35. In India, hardly we get this much of the BMI at any point of the age. Even the pregnant women are having the BMI of 20, 22. So it is really a thing which is to be answered only by the randomized control trials, or when we have some planned study, really metformin is a right choice for the Indian population or not.
Just a small quick question.
It's a, just one thing. It's a right thing, but Dr. Anuj Maheshwari has already discussed. Even in our patient, we can use glyburide. The thing is that you have to take a written consent from the patient that we have discussed with the patient the pros and cons of insulin, the pros and cons of the glyburide. Take a written consent, then only you should give. Otherwise, it is always it is good to start insulin, or metformin can be added. Those who are actually bit obese, so in that case, metformin can be safely added to that. Sir.
Yeah, just a small question. Like we advise annual checkups or the general checkup of lipid profile, urine, albuminuria to all diabetic patients. Like we advise frequent A1C. Do we advise sonography for all diabetic patients to detect fatty liver? 1. 2. Is there any cheaper way to regularly check the fat content of the liver, or the apart from fibroscan or apart from even sonography itself, which is fairly costly in metros, and probably may not be possible in the periphery of India or even the all Southeast Asian countries. So what can be the thought on this, Dr. Madhu and all of them?
Yeah. We can do the fibroscan every 3 years for all the diabetic patient. That could be done.
Yeah, the question is, if this is not available at the ground level, sir, the most important thing is you just take a waist hip ratio, you just take a abdominal circumference.
Anthropometric.
Yeah.
No, I agree.
That will give a clue that who are the subset of people who needs additional therapy or additional treatment. Because
so obese people.
Yeah, even if
but we are thin obese.
No, let me
don't know the liver.
Let me please.
There was one slide I talked about. There is a lean patient whose BMI is less than 25.
Yeah.
And in that scenario, we can use the lean body weight and with the additional 2 risk factors, that is in a pre-diabetic state or pre-hypertension state and waist circumference and
those patients.
Yeah, in this we can do the 2 risk factor and we can diagnose it as a MASH.
Yeah, the most important part is you first, once you are taking the anthropometry, from anthropometry you will have a clear-cut idea that who is the risk people. Once, if you are taking anthropometry, still you are missing 10-20% people, you will miss. Then there the thing comes, those who are having dyslipidemia, those who are having pre-diabetic, this also, even despite of low body weight, they also should be screened for this animal.
My purpose of question was a bit different. I have had recently 2 patients who are non-diabetic but obese, but have developed liver cirrhosis later on to the extent that they required the transplant. So what I'm coming to is to detect the liver fat earlier, cheaper, comprehensively, something like POC of A1C machines we have, the point of care machines. This is what my thought was. Thank you very much.
Yeah, thank you. I have a question for Dr. Maheshwar. I really liked your talk. It was very, very comprehensive. I know this is not always affordable or feasible, particularly in Southeast Asia, but have you considered in a subset of the population the use of CGM in gestational diabetes or planning to become pregnant women? Because we funded a very large study called CONCEPT, which demonstrated superior outcomes for both maternal and fetal outcomes just by the use of CGM. And this is 15 years ago with the older CGMs. So have you considered that?
Yes, definitely. We consider it, and we have done many of our patients also. And if in fact it is more useful when we are doing pre-pregnancy screening. So pre-pregnancy screening, we really do that. 2-3 benefits could be there. Of course, we can know whether patient is in having the glucose intolerance, whether the patient is having the diabetes or hidden diabetes, may not be maybe undiagnosed diabetes. But at the same time, patient may also know that what food material is causing what level of the rise in the hyperglycemia. And that helps in when she enters into the pregnancy. And even in the pregnancy also, we can continue doing that, although the targets remains different. In the pregnancy, our targets is less than 120, but when you are putting up the CGM, you can know what level of the hyperglycemia your pregnant women is achieving. So it's really a very useful advice. If it can reduce their prices, definitely it could be a boon in the pregnancy when the cutoff is very, very short, and many a times it is too close to the normal, and hypoglycemia chances are very much high.
And we are beginning to see it's superior to A1C because you can do it in more real time.
Definitely.
Dr. Helen Murphy and many others have demonstrated that pretty well. So,
agree.
The last comment, the last line in your slide, that insulin still the golden standard for management, because whenever you ask the patient to have insulin, 99% refused. So we must have the educational tools to convince the patient for this. And one remark also for metformin. Metformin needs a very long run follow-up to see what about the offspring effect, and we cannot guarantee at this moment that metformin will improve the insulin sensitivity, will be a good tool for the GDM.
In India,
Sir, I have a question.
Glyburide is not approved to be used in pregnancy.
Sir, as many diabetics, they have underlying cardiac functions. We are doing the many tests routinely to find the other things. can any role of anti-pro-BNP levels doing that in the diabetic patient, as this test is now available in the periphery level also? Thank you.
Actually, we are just now funding a study now to correlate the NT-proBNP levels with cardiovascular disease as a very early marker that rises up here. We don't have the results yet, but it's a RCT that we are funding at the moment, but in people with type 1 diabetes, which is the focus of our organization.
Again, for Indian as prospect to do NT-proBNP, each and every patient is still not indicated. So you have to see if there is risk factors, then definitely you should grow. But still, for each and every patient of type 2 diabetes, it's not indicated to do in each and every person.
Let me ask my co-chair a question. So is it time to develop a risk algorithm for Southeast Asia based on all these co-segregating morbidities, like CRN and NASH and everything else? Is that based on the BMI and waist to hip circumference in Southeast Asia, which is significantly lower than that in the Caucasian population? Is it good? I'm asking my co-chair here to develop a risk.
Yeah, actually, yesterday there was a discussion under the chair of Dr. Anuj Maheshwari, probably Shashank Joshi, and few of us, we are taking the charge that we will definitely come out with the risk scores within the next 1 year. Definitely, we are planning that. So if there is no questions, we'll end the session. And it is up to the organizers. Thank you, all the speakers, and thank you all my co-chairs. Thank you. Thank you.
Thank you.
For the next session, we have chairpersons, Professor Dr. Kamalakar Tripathi sir, Professor Dr. Manoj Chidda sir, and Dr. L. Srinivas Smith sir. So request all the chairpersons to come to the dais.
Good afternoon, friends. Thank you for being here for the next session, which is again a mixed bag. Our first speaker is Dr. Manika Suman Tilke from Sri Lanka, and I'm waiting for his proper biodata because with his name they put my biodata. But we were just having a talk before this, and he's going to discuss about the young type 2 diabetic in Sri Lanka, and then we'll see if we have something common in India.
Thank you very much, Chairperson, for that kind words of introduction. I was impressed by the resume, which, all the PhDs and all that, and thank you anyway. So let me first of all thank Diabetes India and the DASG for inviting me today, and a very interesting and a challenging topic, and a topic of the Ahmedabad Declaration as well. So, young onset type 2 diabetes. In this, the pathophysiology or the etiology, all these factors we'll try to quickly go through: the beta cell dysfunction, the lifestyle factors, the genetics, pollutants, and the in utero exposure to diabetes, so on and so forth. It's a problem in our part of the world, but worldwide, you can see the numbers are staggering, and a problem in other parts of the world as well. Let me start with our very young registry that we just started a couple of years back. We have about 3,000 to 3,500 patients registered so far, but this is less than 25 because of the staggering numbers. It's a cloud-based, multi-center throughout the island registry that we started for young diabetes. We have analyzed the first 2,500 or so patients, and these are the statistics we got. Majority were type 1, and about 35% were type 2, young onset, less than 25, mind you, not the 40 usual cutoff. And the other types of diabetes was about 8%. This is compared to a recent Indian study where they had 40% each, but this is less than 40 years. That's the difference in the Indian study. So it was like type 1 and type 2 equal, and a higher number of pancreatic diabetes is noted in India, which was not the case. Only one case was there out of 2,500 patients in our study. And, genetic diabetes is about 3% in your cohort. So in our cohort of this 8% of other types of diabetes, and the patients who are in my personal clinic at the National Hospital in Sri Lanka, 53 patients I analyzed for these 13 genes of MODY just to see how things are. This is not a prevalence study, but to look at the etiology of the others. And out of the 51, but there is a selection bias here, and out of the 51, about 24 were positive for one of those some of the genes that I have shown here, the 13, with the highest prevalence of 31% for MODY3 in our cohort of less than 25 young diabetes cohort. And of course, they had varying levels of mainly microvascular complications, not much of macrovascular complications, and the vast majority were on insulin. And some of them, the MODY tested ones, we were able to get them back on oral hypoglycemic agents after the testing because they were treated as some as type 1 diabetes. And the characteristic population data, strong family history in most of the young people, and the HbA1c is uniformly more than 8.5 in the majority, with the complication rates showing nearly around anything between 5 to 10%, and dyslipidemia was the highest comorbidity, the associated in about 15% of the patient. So when you look at the world data, we notice that our percentage of type 2 in that group was higher in the less than 25 group, and the 57% of patients age 18 years or above were obese, and 73% of the younger 5 to 18 group were obese in our cohort. So you all know the problems, so the challenges for the future also can be identified, and poor glycemic control and investigation. A study done by the Diabetes Association in Sri Lanka 10 years back, along with King's College London, had a glimpse of what would be the prevalence in Sri Lanka at least, and I think it's comparable with the Indian data, although it's a bit old. Here, 20,000 patients, 5 to 40 years. I'll just concentrate on the dysglycemia only. The risk factors prevalence is given there. It's about 8.2%. And more than 20 years, 22%. And our national average done recently came as 23% for diabetes in adults in all over the country. These are more relevant, more recent meta-analysis done by some of your colleagues, looking at the pediatric obesity rate in South Asians, 5 to 19 years. Very recent publication. About 206 million have been identified. Within India, it's about 6.5% obesity, Sri Lanka 4.8, and the average is also about 6.6 with a overweight and obesity prevalence of about 20%. So you know the challenges. Obesity, childhood obesity is going to be a key challenge for us with youth onset type 2 diabetes, and the urban-rural divide. The prevalence is about double, 24%, 21% versus 10.2 in urban versus rural in all these studies in all parts of Asia. That's been noted. That has been shown in many studies, and the challenges ahead for us. And this was, I think, this article by Dr. Mohan and his Kelly West Award lecture, which we listened to recently at the ADA, summarizes all the problems associated with the problem of youth onset type 2 diabetes, especially the South Asian phenotype that we are talking. He looked at the South Asians in different countries from Fiji to Canada, and they all came up higher in the prevalence rates were higher compared to other ethnicities. And here, what's peculiar about young onset diabetes, it occurs especially in the South Asians at a lower BMI, younger age, high risk of unfavorable fat distribution. I think this has been repeated many times, the liver fat and the pancreatic fat, and high genetic risk of insulin deficiency, initial insulin resistance, but they quickly go in for insulin deficiency, poor response to oral hypoglycemic agents, and rapid progression to microvascular complications. So this is the challenge that we have in our region. So the ALPIS, you all know ALPIS came out with this classification for etiopathogenic classification for diabetes, knowing with the genetic the understanding of the genetics and the antibody status of diabetes. Severe insulin deficient diabetes in South Asians is supposed to be more common. And in this article, he summarizes nicely what happens, the life cycle of what's happening from preconception to conception, GDM, overweight and obesity in adolescents, leading to low birth weight or high birth weight, which all amounts to increased fat, and overfeeding later causes excess fat or adiposity, or the thin fat Indian, or what we call the fat overflow hypothesis, and the increased liver and pancreatic fat, and hyperinsulinemia. Mind you, even now IDF president said that it's 1/5 of the type 2 diabetes is caused by air pollution. And there's a lot of evidence now that air pollution can increase the insulin resistance in many ways. And all this leads to what you call as young age onset with a lower BMI type 2 diabetes in our part of the world. In this study, it's very interesting. The wheel has gone the full round. Earlier, we used to say data South Asians, especially Indians who migrate to Western countries, showed an increased prevalence of diabetes. And now, in this study by, again, Dr. Mohan shows that in Chennai, in the city, the prevalence of diabetes is much more than similar South Indians or Indians living in San Francisco and Chicago. So it's the changing lifestyles, not the genes, that has caused this change, as shown in many other studies. And again, he shows that in India also the rural, the urban divide is shown there in the prevalence of type 2 diabetes. And the lower frame, the B there, shows the onset of diabetes is about a decade earlier for the South Asians, Southeast Asians, compared to especially the white Europeans. And also the prevalence of the peak prevalence also comes about a decade earlier for Southeast Asians. So what's happening here and what are the challenges? So the subtypes in diabetes, this is not accepted all over, but it fits well with this problem, the etiopathogenesis. So there are studies to show that insulin resistant, severe insulin resistance and combined insulin resistant and deficient diabetes is more common in our part of the world, 40% versus 17.5% in a Scandinavian study compared to the European. So these are all interesting new things and concepts that we have to think of. And this was done in Scotland, east of Scotland, where the Indians living there was compared with the natives, and it clearly shows this hypothesis that the same BMI, you can see the prevalence rates of diabetes was much higher. C-peptide levels were much lower in the South Asians, and lower genetically determined beta cell function. So that's interesting. There are lots of papers coming about this genetically determined beta cell function and why we are having a so-called the thrifty gene, or the genes. People are zeroing in on these genes. So these are very recent Nature Medicine paper done in UK in Indians living there, and they have compared with the white Caucasians, and they showed a higher rate of diabetes, which we say anyway over and over again. But this is interesting. The partition polygenic score, that they are a way of looking at the contribution of certain genes for the pathogenesis. It's coming up this beta cell 2, that is a insulin reserve of the beta cell. So basically low levels of insulin, lipodystrophies, differential distribution of fat. This gene controls more deposition of fat in the liver and the pancreas compared to the other areas, and the obesity related genes are coming up on this score as contributory factors for this young onset type 2 diabetes, mainly seen in Southeast Asians. And of course, they have looked at their response to oral medications. Metformin, DPP-4 inhibitors, SGLT2 inhibitors, all that is showing that they go in for OHA failure early in people, those who have these 3 genes, which was mentioned before. It's sort of statistically significant value. So you can see that our young people, they quickly need the insulin, and out of this, sulfonylureas, although temporary, may show a better, actually a response compared to the other medications in this cohort of patients. So things aren't the same even in East Asia, so I didn't take a lot of data in the interest of time from that region, but it's not that as staggering as Southeast Asia, but it's a problem in East Asians as well, as shown in this study from Hong Kong. So what are the problems? Biological factors, lifestyle factors, urbanization, immigration, all that. How do we tackle this? That's the most important thing as a region and a country. So we know the pathophysiology, but not the genes for sure. But look at the suggested risk factors. Some are easily modifiable. If you may see low B12 levels, low vitamin D, and in another paper it was the high folate levels. We sometimes overtreat, pre-pregnancy. That also can have effect, and fatty liver has been discussed, and primordial prevention, I would say, could address some of these risk factors which has increased the risk of youth onset type 2 diabetes in our region, and many other factors. Individualized treatment for your patients. They might have some of these rarer forms. Pancreatic diabetes, in that cohort, you all had 15% in India. In our study, it was like 0.001, very minimal. So that should be looked into. So it's like a 80-20 when you look at the breakdown when it comes to type 2 diabetes, and MODY, LADA, and atypical diabetes, genetic diabetes, all that could be mixed or misdiagnosed also in this group. And we can't do anything about our genes, but certainly lifestyle factors and, if you attend to them, epigenetics can be altered, especially environmentally induced epigenetic changes and the lifestyle related epigenetic changes, mainly maternal hyperglycemia. If that is attended to, these epigenetic changes can be altered in a better way so that you don't go up the pyramid and end up with type 2 diabetes. And stress, pollutants, smoking, alcohol could be easily addressed by all of us in our countries. I think this is one of the most important slides in my lecture. I would say that, if you work on primordial prevention,
preconception counseling, weight reduction, avoiding dysglycemia in pregnancy, pre-GDM or early GDM, EGDM study has there. Don't wait for 24 to 28 weeks. In high-risk people, better to check them even at the booking visit, or less than 20 weeks of gestation, you should check them. And then data is to show the Harper study, you remember, continuing risk increase in the neonate in all parameters with rising maternal hyperglycemia. And the follow-up studies clearly shows that higher levels of glucose, exposure to glucose in utero is associated with childhood insulin resistance and other metabolic problems in future. So what do we do? If you can, population approach will be the way forward for India and Southeast Asia. If you can reduce 10% of the carbohydrate intake in our people's diet, I think we can make a huge difference. And Peter was, IDF president was going on about frying the carbs and the fatty liver. So if you could reduce the cooking method, or India can come up with a, cheap air fryer for the region. I mean, at least part of the population, the way we cook, if that is changed, the population approach, a huge difference can be made, impact on the fatty liver and the onset of youth onset diabetes. So it's a life circle theory that we are talking about. And looking through the topic, I went through our Diabetes Association database, looking for some slides, and I saw that this Kathmandu Declaration, most of us wouldn't have been there at that time, the seniors would know, by the IDF, they came up with the same solutions, the life cycle solution for young diabetes. I think preconception or primordial and primary prevention would be the way forward. And I'm happy that we have the Ahmedabad Declaration, which has addressed most of these issues, and hopefully we can get together and make a change. Few things on advocacy from Sri Lanka I would like to share with you. If you could try the traffic light system, this labeling of sugary drinks and products with red, amber and green has made a big, at least a reasonable impact on people choosing them, and the manufacturers actually who are red has reduced their sugar content in their drinks to amber. So that's, population-wide approach. And now Diabetes Association, this is not by law, but, people who are volunteering in the sugar sachets, we put sugar is addictive and causes diabetes, like in the cigarette packet. So maybe we haven't done a study to check the effectiveness, but it works. Sugar taxes we promoted in 2017 for sugary drinks, a small tax depending on the sugar level. And these are the things, other things, and innovative ways for screening. Diabetes Compass, I'm the project lead for this. We are trying out an app, offline app, looking for high-risk people in the community and guiding them to the nearest hospital visit free of charge, which is there in Sri Lanka, to get their sugars tested. And with the twin cycle theory of Roy Taylor and the remission of diabetes, I would say newly diagnosed young type 2, we should all strive for remission, which could be done with a very low calorie diet, managed in the primary care setting with not much expertise needed. I would get you to read the direct study where the diabetes nurses did the job, not the doctors, and they reverse in about 46% of the patients at the end of 1 year. So it's a very good way to go. And we have developed in Sri Lanka a carb counter app. This mainly for the type 1 initially, but it's very useful for type 2 and even for people at risk. We have given the photographs. Some of the Indian foods are also there, and they could get an idea about the load of carbohydrates in their diet. So, ladies and gentlemen, last two slides: population interventions, holistic care, and multidisciplinary treatment. Starting from the family, inculcating good lifestyle in children and good diet in the family. If the father gets diabetes, children also should. It's just a balanced, healthy diet that we are recommending, nothing special. This part of the world, sometimes we see people have a special diet for the person living with diabetes and another diet for the family. That should not be the case. And we have taken this teacher-child parent approach.
in Sri Lanka, we have tried this. It has worked very well, where we get the nursery children in the form of a cartoon with a thin and a fat bird, and giving them lifestyle advice on diet and exercise, and they have taken the message to their parents. And after all that, we need the holistic care, as was mentioned by previous speakers as well, in managing our young type 2 diabetics to prevent them from getting many complications of diabetes and leading a happy life with diabetes. Thank you very much.
Thank you. And Dr. Sumantil, it's great you've brought the problem out, that the extent of it and some solutions at least. In India, we've been doing a similar young diabetes registry for the last 14-15 years. And on data, we have about 23,000 young diabetics, and maybe next time we'll discuss that in a little more details. Thanks a lot.
We now have the Dr. Vivian Lin from Singapore. She's a graduate of National University of Singapore, MRCP from Royal College of Physicians, UK, Master of Internal Medicine, and Advanced Specialist Training in Endocrinology. She has been an executive committee member of International Society of Endocrinology, past president of Asian Federation, president of Endocrine Metabolic Society of Singapore, a lot many credentials. She has been chairperson of the Mayo Course and Healthcare Humanity Award 2014. Over to you.
Well, thank you very much for that kind introduction. Okay, so I was given this mandate to answer this question: continuous glucose monitoring in diabetes management, do they really help? So this continuous glucose monitoring here means flash monitoring or real-time monitoring. I use them all. So I only have 20 minutes to answer this, so I'm going to move on now. Now, I've got no financial disclosures, nothing for the purposes of this talk. Now, given that this is in a symposium known as Diabetes in Asia, I thought it apt to bring out this IDF atlas around the world. Now, if you take a look, this is 1 in 10 adults with diabetes, 537 million worldwide. This is a very, very common condition. I'm going to dredge out Southeast Asia here, and you see 90 million and going up to 152 million, which is 68%. There is something a little bit odd here. You are not Southeast Asia. I come from Singapore. Geographically, you are South Asia. I'm not sure why, and I've asked Peter Schwartz, and nobody knows why. So it's considered Southeast Asia in this region. If you look at this, this is geographically Asia. This is South Asia. I'm Southeast Asia. So interestingly, the next speaker is China, and from China. So we are considered Western Pacific. We are very, very different. Yeah, East Asia, China, Southeast Asia, where is Singapore, is there as well, and Australia. So go figure. And just wondering, if you're wondering where I'm from, I can't find myself. I have to squint. That's exactly where I'm from. That's Singapore. It's a little red dot. You have to imagine. So the question then is, continuous glucose monitoring in diabetes, do they really help? Now, to know this and to see how far we have come, let's go from the very beginning. Did you know this, that in the 1600s, the doctors have to diagnose diabetes by tasting a urine, talking about giving everything for medicine. Now, interestingly, I got this out, and in the 5th century BC, given I'm having a talk in a minute about now, the famous Indian, apparently famous Indian surgeon, you might know him, Shushruta, in his work Samhita, I'm sorry if I pronounced it wrongly, identified diabetes by using the term madhumeha, which is honey-like urine, and pointed out not only the sweet taste of the urine, but also its sticky feeling to the touch and its ability to attract the ants. They put in exclamation mark. I copied and pasted. It was really in the article. Happily, since then, in the early parts of the, in 1900s, we started having Benedict's reagent, and with different colorings showing the different concentrations of sugars. And then we have this, some of you know this, we still have this in a lot of outpatient settings where it's semi-quantitative in terms of glucose. And then in the 1980s, that's where glucose monitoring came about. And then 1990s onwards, really actually in the last 1 decade. And this is the timelines of CGMS from the 1999 until now. So again, really in the last few years, in the beginning, it was clunky. It was also only 3 years, 3 days that you can use it, quite a lot of issues, but then now we have more and more, and it's more rapidly developing. So the question then is this. So does it really help? Well, with the talk will focus on 3 aspects. Then number 1, logically. Number 2, data. And I'm going to go and give you clinical scenarios. So logically, remember this chart. Well, I mean, for me, I would prefer not to taste the urine of my patients to determine whether the glucose is high or not, but that's me. If you have a different thinking from me, of course, you're welcome to your opinion. And obviously the glucose in the urine is quantitative, so it would be great for me to have something which is going to be continuous. And I remember the times, I remember now, I've got patients coming up to you, remember they prick, and then you can tell whether the person really does it or he's faking the results by the blood stains on the finger prick report. So, well, it's ouch. And sometimes for my diabetic patients who are gestational diabetes, sometimes 9 times a day they have to do it. That's a pretty poor thing. So, and no matter how many you do, it's like a blind person touching the elephant. You are not seeing the complete picture. This is opposed to CGMS, continuous glucose monitoring. And this is CGMS 24/7, 365 days if you decide to put it on. So this has revolutionized diabetes through the years. So that logically, to me, certainly I want CGMS. Now, what about data? Do we have data? Yes, we have lots and lots of data, but I have stretched out the 2 reports in the 2025, and they're from real world evidence from this. So one of this is this, which is a meta-analysis of 8 observational studies, assess the change in HbA1c at 3 to 6 months following initiation of flash glucose monitoring in type 2 diabetes, which are treated with insulin. So these are 8,800 patients, mean age 62, mean HbA1c is 9%, and they found that the initiation of CGM led to a mean decrease in HbA1c of 0.89%. That is equivalent to 1 medication. So that's a second data that came out. This was, to me, even more evidence in terms of this, because not just HbA1c, but clinical outcomes. So initiation linked to improved glycemic control that we saw just now, and also fewer clinical events in both type 1 and type 2 diabetes in the Veterans Health Administration. So you see the whopping numbers there, because this huge database from the VA hospitals. So this is type 1 diabetes, 4,900 against 3,000 over type 2 diabetes, 15,000 who initiated it against 28,000 who did not. And this is in 1 year's time. What was the 12-month change in HbA1c? Okay, so this is 0.26%. Minus 0.26, and then for the type 2 diabetes, minus 0.35. What about the clinical events over 12 months? Looking at hypoglycemic admissions, we have 0.69 for type 1 diabetes, 0.92 for type 2. Hyperglycemic admissions, 0.83, 0.87. And all hospitalizations, 0.75 and 0.89 in terms of initiation of CGMS. So you have, logically, you have data, and then let's look at clinical scenarios to see some tips for practice. So this is case 1. She's all these are real patients. Yeah, 48-year-old female, diabetes, diagnosed since 2014, first seen by me on 23rd of November. She's 7.5% on glycoside, 7.5 milligrams in the morning, 5 milligrams at night, metformin, 500 milligrams 2 times a day. The 1 hour postprandial is 11.7 and fasting of 8.0. Family history strong on the mother's side. What do you think? Run of the mill, right? I can give her another medication, it's all good, just lose weight, eat healthily. When she was first diagnosed, she was 42 kilograms, 1.57 meters. Her current weight when I saw her was 36.3 kilograms, BMI of 14.7. This lady is starving herself just to get on 2 medications, 7.5%. And yet, despite that, the fasting is 8.0. She is not run of the mill. Something else is going on. So her HbA1c then was 6.9% on starvation diet. We have 27% is high. I'm not here to teach you how to use it. It's just the mandate. Is it going to be helpful? So I'm going to show you why. So this was 24/7. And this is how it is. So variability, quite a lot of variability with the food. She eats a little bit. Remember, she's BMI of 14.7, yeah, 36 kilograms. She eats a little bit, boom, it still goes up high. How much can she eat? 3 months later, this is her variability. What did I do? I managed to convince her to start insulin. 2014 until 2022, refused. Until now, she finally, the HbA1c was 6.3%. Novo Rapid 3 times per day when working for home. Otherwise, it's a minimum of about 2 times per day. Tojo 9 units, very sensitive to insulin. Yeah? She was managed to put on 36.3. Now, weight is a complex issue, but so she managed to put on 36.3 to 37.7 kilograms. So this was what she was before, and this was 3 months later, a difference in 6.9% to 6.3%. The highs much less now, and the variability is also less. And this is how she was after 3 months, and on almost basal, is a almost basal bolus, or rather bolus plus, a basal plus. So the learning points for this is a patient who starved herself, was very severely underweight without the CGMS, without looking at it. I'm giving it to her. I'm letting her look at it. She finally understands what it is. Why is it, no matter how much she starves, the glucose is still going to be high. There's something else inherently going on. So this is a picture paints 1,000 words. And that is helpful to convince my patients to start insulin. It doesn't have to be her. Hers was just an extreme case, which was interesting that I brought up. So able to help. So with this, you are able to help the patient to start insulin and also to escalate management, because there's a lot of inertia with regards to escalating management, whether it's adding on another oral hypoglycemics or whether it's adding on insulin. Now, this is a second case, 57-year-old female. She was referred by an oncologist, breast cancer, neoadjuvant chemo and surgery. Baseline pre-chemo bloods came back, a random glucose, which is sky high, HbA1c 11.5%. She never knew she had diabetes. She didn't have any inkling. Family history, diabetes, but she's a known case of hypertension, BMI 24.8, weight is 63.4. And I first saw her on 16th of February 2023. This is not uncommon, yeah, whether your cardiothoracic surgeon comes to you, they think you can work miracles. Oncologist comes to you and say, I want a chemo on 21st of February morning, and I'm going to give her IV steroids, and she's just going to dump it in your lap. Okay, so what did I do? Slept on CGMS, start drugs. So let me show you then what happened to this gentleman. Let's say, oops, okay, this is not working. Any IT guy? No IT guy. It worked just now in the preview, but it's not working now. How do I play it? Yes. Okay, never mind. Let's not waste time. We'll go on. Because it did work in preview, during the preview. Okay. Oh, here we go. Now it works. Okay. Okay. So, now I can't stop it. The barriers to diabetes management and the use of CGMS. Okay. Now I can get rid of it. Oh, here we go. Here we go. I don't know how. Okay, so we started here. Okay, so it's beautiful. It's the picture paints 1,000 words here. So started here. I put on the oral medications. I started on insulin, basal insulin. Yes. Now within 1 day, that's your levels. Then remember, 21st in the morning, they wanted to start chemo, yeah? Okay. 19th February, 20th, 21st. Yeah? Can start chemo, no problems. Open heart surgery, also possible. But then the oncologist said, I'm sorry, we didn't have bed, so we are not starting chemo now. Okay, never mind. Moving on. So guess when chemo was started? You can tell. This blue. Chemo was started here because chemo came with DAXA. So this shows you what happens after dexamethasone. Okay? And you see after the dexamethasone, it's at a higher level, the fasting insulin. So steroids is bad, bad, bad for diabetes. And then afterwards, it takes some time, and then it goes down again to baseline, what it was supposed to be without the DAXA. Okay, so that's, now I want to show you. Okay, so then, right. Okay, so if this was initially, it's 6.5 because that's the other thing good about CGMS. HbA1c 3 to 4 months, yes, because of the red blood cell lifespan. But on the CGMS, it's 2 weeks. Within 2 weeks, I know that it's working, it's 6.5%. This is 5.7% after. And this is what it was before that, and then you have it now. The learning point for this is helps to alleviate stress. Why? This is a patient who was newly diagnosed with breast cancer, operated, and then now she's told that before she's giving chemotherapy, she has diabetes, which she never knew that she had. So this is a very stressful situation. She doesn't know what she eats. She doesn't know what to do. So this helps to educate where the carb sources are. Just with that, the dietitian gives you theory. They can tell you that carbohydrates are in this. But for her, for anyone who's on the CGMS, that is targeted to what they are eating. They can immediately see where the carbohydrates are coming from. And therefore, I use them whether it's newly diagnosed after oncology, after breast cancer, or a type 2, a type 1, anything. Just because it's good to educate on where the carb sources are. It also captures continuous data over different situations after DAXA, and also after exercising, educates on activity and glucose. So even if I had to use it, even if I use it once, I'll be very happy with this. And my patients feel very happy with that as well, because they get to see the different things that they do and how it impacts on glucose. Now this one, I hope this. Okay, you just take a look at the glucose, okay? Just take a quick look. Okay. Oops. Question, what have you noticed? Yeah? If I told you then, this is a Singapore king of fruits. 1 kilogram, it's 25 US dollars. It's very pungent. It's banned from hotels. It's called durians. This is Musang King, Mao Shan Wang. It's a fruit, but 3 seeds of this is 27 grams. There was this patient ate 30 seeds. That's 270 grams of carbohydrates. 15 grams is 1 slice of bread. That's a lot of slices of bread. 8.3. What does it say? That was me. You need to know, this is good to me, just for the fun of it, to know what normality is. That glucose is actually very controlled and very tightly controlled in patients with no diabetes. To be careful in overdiagnosing about hypoglycemia. Technology is everywhere. I love this because not to show my glucose levels, because I have patients coming up to me because they have slept on CGMS and they say they have hypoglycemia, but I show them mine and show them that actually there's overdiagnosing there. Also, hypoglycemia is an artificial construct. You know, it was not 3.6. Yeah, the Whippers try it. It's 2.8 millimoles, it's neurosymptomatic, and then relief with glucose. So it's slightly different, yeah. So the second thing is that you use it for patients as well, because the patients who remember about the proactive escalation, and there's a lot of inertia in increasing, whether to insulin or otherwise, to show them what normality means. So able to compare. If it's always on the high levels, they have come to me before and told me that, my body works on a higher level than everybody else. I don't feel anything, so that's good. It's no need to bring down the glucose to a normal level. So this helps me with all these groups of patients as well. So now, this final case then, she's 28 years old, Miss AH. She's diagnosed, 21 years old, started on insulin. Referred by eye doctor who saw her for bilateral proliferative diabetic retinopathy, vitreous hemorrhage, needed intravitreal anti-VEGF. The medication she was on was basal bolus, glargine 30 units at 10 p.m., glucosin 20 units 3 times a day, empagliflozin dual 12.5 850, amlodipine, carnosartan, so lipids and diabetes and hypertension. If I showed this to you, if I showed this to you, it tells you a different picture. It tells me type 1 or type 2. This is type 2. This is type 1. There's no insulin reserves. So from that, it helps physicians to see, it helps me to see whether this is type 1 or type 2. And if this is type 1, this is type 2, because why is it that type 1 is all over the place? Because there's no insulin reserve. You don't have enough, it goes up. You have too much, it goes down. You have hypoglycemia, whereas type 2 looks typically like this. And this is important to me because when she comes to me on basal bolus at 28 years old, and is type 2, why is she on basal bolus? Her HbA1c was 5.6%, her C-peptides was 3.54, beautiful. And her weight was 89.3, and her BMI was 34.9, class 2. The weight keeps increasing, it never could decrease. So what do you want to do? So what happened was, I saw her on the 10th of January. I told her, you are taking off all your rapid-acting insulin. She looked at me in shock, and she was very fearful. I said, stop it, you take 30 grams. She was a very, very bright lady. She knew where her grams, she could do carbohydrate insulin counting. But I don't know why it's 20 units 3 times a day. So I say, take off all over rapid and give me 30 grams per day. This is 2 dinner, 1 dinner, 1 breakfast. See how flat it is. So within 12 hours, I have decreased the insulin dosage by 60 units per day. I saw her via Zoom on the 24th of January 2025, which is 2 weeks later. Her line continued being flat, 0 glucosin, 0.6 milligrams GLP-1 started. Glargine was dropped from 30 to 22 units. Weight loss of 3 kilograms in a lady who had to chase 20 units per day and ate 20 units per day and couldn't reduce weight. I updated just for this talk. I asked her how she was doing. She was not in Singapore. She's actually in Indonesia. And that's one of the great things of this because you cannot hide from the doctors. We tweeted out and then we had a Zoom and I could share screen with her for CGMS. Updated on 13th of February. That's how it looks. That's flat. And that's still how it looks. Lentils was 12 units, 84 kilograms, lost further weight. And what did I tell her? I say you go down to 8 units, and then just before I see you, which is in 2 weeks from now, give me 0 insulin, and let's see how it goes. And if you're wondering why is it I do that, and why there's CGMS, because it's reassurance. She's been all her life on insulin, and she didn't dare to remove it. So the learning points from this, CGM profile is very helpful to me, to aid in differentiation of the types of diabetes, a close monitoring to see the success of the insulin removal and to allay the anxiety of this patient. And it aids my patient to see where the carbs are coming from, and to decrease carbs, you also aid in weight loss. And it's a confidence booster to see that there's no hyperglycemia and that she could continue on this regime. So in conclusions, if you ask me then, the mandate I had was to answer these questions. Continuous glucose monitoring, diabetes management, do they really help? Logically, yes. Data-wise, yes. HbA1c as well as clinical outcomes data. Clinical scenarios, definitely yes to me. I am so pampered. I can't do without this anymore. And in fact, some of my patients tell me that they want to continue. I say, why are you continuing? It's flat. It might be for reassurance. It might be because they are globe-trotting. They are so obsessive. They want to know where the carbs are coming from. I say, whatever rocks your boat, that's why. For me, I might not need your CGMS. If you want to use it, if you feel that it helps you, go ahead and use it. But of course, we live in the real world. Cost effectiveness, one thing. I would definitely use at least once for a type 2 diabetes, but I'm aware that it might be expensive depending on which flash monitoring device. But I also know that advanced technology is coming and it's getting more cheaper and cheaper. So, I'm going to answer that question. Do they really help? Yes. That's not about cost first, but do they really help? Yes. Invaluable in the practice. Thank you very much.
Thank you. Thank you. We would be taking question at the end of the session. So next is Dr. Raming Ho from China. And he would be talking on the new factors in the control of glucose. Dr. Ho is extremely brilliant person, seems to be. He reverses chronological order. That's what the research area is. And he has been working from 1986 to 88 as attending physician, Department of Internal Medicine, endocrinology at Shanghai. And 88 to 90 he was the University of Chicago doing the endocrinology laboratory fellowship, postdoctoral fellowship, assistant research fellow, University of California, and lot many credential, deputy director, administrative position. Very senior person seems to be. Okay to you, sir.
Okay. Dear Chair, ladies and gentlemen, it's my pleasure to be here talk on new factors in the control of glucose. Well, it's well known. The mechanisms of glucose regulation, including iron cell producing insulin and glucagon, and the feedback loops. Well, recent years, it is found so many factors also involve the process of lowering or increasing glucose. So in this period, I would like to talk some data from our lab. First one, the cloning and the function study of TM4. What's mean TM4? This protein contains 4 transmembrane domains, so we call TM4. Well, TM4, SNP study shows the TM4 associated with obesity. Well, TM4 was downregulated in the human, the visceral fat in the patient with obesity. And TM4 knockout mouse appears hypertension, high glucose, obesity. Well, the low-grade inflammation in the liver and adipose tissues. TM4 to regulate NUR77 IKK beta. Also, TM4 can decrease appearance of atherosclerosis. So looks TM4 as a very good model induce diabetes, obesity, fatty liver, and atherosclerosis. Second protein we call EMC. This is circulating the proteins, which was significantly increased in the muscle or in the muffled patients. Well, it was found that EMC10 is involved in occurrence of muffled. Also, inhibit muscle GLUT4 activity and glucose uptake. So it was considered EMC10 is a type 2 diabetes glycemic factor. Well, since EMC inhibit first phase of insulin secretion, we also demonstrated that EMC10 inhibits insulin secretion in pancreatic island beta cells. We also demonstrated that the serum EMC10 was positively correlated with obesity. And promotes occurrence of obesity in the mouse. Well, another data is about LPS and microRNA. Well, plasma LPS was significantly high in the newly diagnosed patients. LPS decreased the transcription of microRNA 143, 145 cluster. MicroRNA 145 decrease NF-kappa B activation. Well, so that we understand LPS can come from disbalance of gut macroorbital. The LPS induce macrophage polarization by inhibiting microRNA 145. So what? The bind to macrophage receptor, toll-like receptor 4. Then they inhibit microRNA 145 promoter. Then they increase OPG and KLF5, which activating NF-kappa B induce low gradient inflammation. Well, another factor is adiponectin. So this is another group found. The adiponectin related to type 2 diabetes, atherosclerosis, obese, and muffled. We found adiponectin in the human visceral fat was reduced. So, adiponectin actually is the co-occurrence of type 2 diabetes, atherosclerosis, NAFLD, and obesity. Another one is isazomin. Is actually can reduce regular blood glucose, fasting blood glucose, and HbA1c. Improve glucose tolerance. Isazomin also can increase insulin sensitivity. Of course, the increased systemic insulin sensitivity. So last one is inflammatory factors. So based on the above the factors affecting the glucose regulation, So we propose metabolic inflammatory syndrome called MIS. Well, we can understand LPS bound to macrophage receptor, toll-like receptor 4. Then macrophage polarization. So this macrophage enter the vascular, induce atherosclerosis, then enter the island, they induce type 2 diabetes. So if the patients with 2 of above 4 metabolic disorders, it was considered as metabolic syndrome, metabolic inflammatory syndrome. Well, first core inflammatory disease is atherosclerosis. About more than 20 years ago, it's published in the New England journals. Atherosclerosis is an inflammatory disease. Well, actually, macrophage involve the whole process of atherosclerosis, including thrombosis. So, from our lab data, we found that the factors are hypoglycemic and anti-inflammatory effects, including TNF4, microRNA 145, adiponectin, isosamine, PS341. Well, LPS and EMC10 looks glycemic and induce inflammation. So based on our finding, the factors affect glucose. So we propose metabolic inflammatory syndrome. So we suggest that the integrated prevention and the treatment of 4 metabolic disorders, including type 2 diabetes, MAFO, obesity, and atherosclerosis. We just start a clinical trial, random clinical trial. We hope get more better data, integrated prevention and treatment of 4 metabolic disorders, including type 2 diabetes, MAFO, obesity, and atherosclerosis. Well, thank you very much for your attention.
Thank you, Dr. Hu. Can I have all the 3 speakers over here before we proceed for a question-answer session? We would like to invite first from the audience. Before audience are ready with their question, I have set of questions for you, and yours seems to be very difficult topic to, most of them are the clinician, and your topic was related with the basic science, so maybe some of the queries have to be answered yet. You talked about TM4, which is a membrane protein. You talked about microRNA 145. You talked about lipopolysaccharide related changes. You also talked toll-like receptor. Now, most of the basic scientists, when you talk to them, this is all are the process of chronic low-grade inflammation. And diabetes is one of the manifestations because all these chronic, slow, low rate of inflammation produce insulin resistance. And this insulin resistance is to utilize the maximum glucose which is available to the body so that body can conserve energy and do the healing. The question remains, most of the molecules which are now developed, like molecule developed for the toll-like receptor, we have TLR1, TLR2, TLR3, TLR4, many varieties of that, is not very specific in the management of either metabolic syndrome or diabetes. So how you develop with the docking effect the specific molecule for a specific disease like type 2 diabetes?
Very good question. Actually, I'm also a clinician. So every day I meet lots of patients.
Yeah.
And in China, actually, even though already got the great achievements of prevention and the treatment of diabetes, but still, so many challenges for us. For example, the prevalence of diabetes still rapidly increase. And the percentage of reached the target still not very high, almost less than 50%. And the chronic complication, including macro and macrovascular complication, still very critical for the patients with diabetes. For example, diabetic nephropathy is a leading cause for end stage of renal failure who need dialysis. So we ask why. So we already pay attention, already got great achievement, but still so many challenges. So we have to think about that. What's the problem? We found that this concept problem, actually the type 2 diabetes is not only one disease. Type 2 diabetes looks is one of couple of disease called metabolic syndrome, or we call it metabolic inflammatory syndrome.
Yes.
Type 2 diabetes just one of metabolic syndrome, one component. So we not pay attention. So we suggest or propose metabolic inflammatory syndrome. The other doctors pay attention. Early diagnosis, atherosclerosis, quite important.
That's true. That brings to another question you raised. Dr. Mohan, in Dr. Mohan series, there was one segment, these are the combined insulin deficiency as well as insulin resistance group of type 4 that you showed in the your phenotype. And you also showed that this patient had very high incidence of diabetic nephropathy as he was talking about. Do you see this particular segment in Sri Lanka?
Yes, if you can remember in my slide, in our small cohort of about 2,500 young diabetics, less than 25, the commonest complication was the microvascular complication detected was nephropathy. Then came retinopathy and the others after that. So there is certainly a connection, and this thing about retinal changes and the nephropathy being, some we see most of the time there is nephropathy without the retinal involvement in our properly diagnosed type 2 diabetics as well. Yes, I saw that that data was presented, but it's a small group. But on the contrary, this classification looks very, very interesting because it explains the etiopathogenesis of
Yes, we had been looking on this specific phenotype, is those patients who develop diabetic nephropathy early. And two different, in this group, one is called proteinuria phenotype, another is called those who have got basic decrease in EGFR, who have got primary glomerular insult. And the drugs, they are effective accordingly. Drugs like finerenone, drugs like cilnidipine, which works on the podocyte specifically, they are good in the reduction of the proteinuria. On other side, those drugs which work onto the basement membrane, endothelial cell, intracellular proliferation, they are the better to retard the progression of the glomerular filtration rate. So that's the innovation, and exactly what he's talking about. Like there are a specific molecule for the toll-like receptor 1, toll-like receptor 4, TLR4 and 5. These are the biomarkers for the chronic inflammatory pathological process. In some of the process, like fibroblasts, they get activated. So as a preventive measure, you use some of these molecules, and they specifically, but they have not been very successful. What I was talking to him, that over the 2 decades there have been newer molecules, bonacenton, then endothelium drugs, abencenton. All these molecules have been developed specifically to stop the signals, but somehow clinically they have not been translated. That's what my message was. One question for you, Dr. Lim, about you said your presentation was excellent for use of shortened CGM, and all his technology expert, Dr. Amit, in front of me, and he loves to use all these advanced techniques. One question always troubles us from the surgeon side. They want to do surgery, and they want to bring down sugar very quickly because the patient is very serious, and they don't want to delay for a long time. They want us to control the blood sugar. So do you want them to put on CGM and then to plan the treatment? Or like traditional, you want to give 4 insulin, 1 bolus, 3 short-acting insulin, and then to build up quickly? One question. Second question, would you like to then put on the insulin pump rather with CGM monitoring before subjecting to the surgical procedure? Third question, we have some of the patient in internal medicine where we require very high dose of steroid, methylprednisolone, 1 gram, 3 consecutive injection, and then waiting for like membranous nephropathy, like proliferative nephropathy, like patient in the status, lupus nephritis. And these patients have got also associated with diabetes. So what's your recommendation in these two groups?
I think this is a challenge of my memory. I have to remember the first question.
It's a surgical counterpart. Surgeons insisting upon doing a surgery in trauma ward, and he wants sugar to come down.
I know. So
another man who, Dr.
So the first question with regards to the surgeon. So the first thing is just send it to me. It's simple. Surgeons, they only want simple things. They want a 1-sentence answer. You send it to me. You don't need to do anything. You don't need to think about basal bolus or putting CGMS. You just send to me. Now he walks over to me because we are in the same tertiary hospital. We are in the same building, right? Just different levels. Just walk over. So when they walk over, I will put on the CGMS. So now that goes into my second question: what to do? Is it insulin pump? Is it that? Insulin pump is a fantastic technology. You need to know where to use it. If your patient is already thinking about surgery, he's confused, he's everything, he's newly diagnosed, forget about insulin pumps. He's going to be confused even more. So I slap on the CGMS and I will start basal bolus, because if the surgeon wants an operation tomorrow, it only depends. If generally they are all very short-tempered people who have no patience. So basically you just slap on, it's like that patient, HbA1c uncontrollable, right? It doesn't matter whether newly diagnosed or not, slap on the CGMS because I need to know what's happening in 24/7. And number 2, basal bolus. That's the best because you are going into surgery, doesn't matter which surgery. If it's an emergency surgery, just go. I will slap on the CGMS and I'll start basal bolus. Then that's the best because insulin, yes, if you're going for operation. If you still have a few days like that lady, basal bolus with orals. And I will take it for because my hospital is next to my clinic. So basically, I just tell the surgeon, it's very simple. You send it to me, I do everything. When you admit the patient, can you please tell me when the operation is? When are you going to do the surgery? I will go and see the patient after the operation. So that's the second one. So it's not an insulin pump. So what was the third question?
Where
Let me
you
dive.
give, where you give like methylprednisolone,
Methylprednisolone. Yes.
3 days and
Yes.
upsurge.
Right. So again, methylprednisolone, when are they giving it for? How are they giving it for? If the person has infection, all this affects how my glucose response is. As you well know, if there's infection, the insulin resistance gets out. So CGMS, I cannot work without CGMS in this group of people.
That's the final answer for all the three. Jyoti, you have to add anything? Dr. Jyoti, you have to add anything? Would you like your patient to go for CGM in your setup, in Indian setup like ours? Yeah, you can use that microphone. Because you are the only right now.
So thank you, Kamala sir. CGM is fantastic because when a person is hospitalized or preparing for a surgery, it is better to go for a CGM because it provides more data. And a doctor will be more confident, as you said, will be more confident to start on a basal bolus therapy in the hospital with the help of a CGM. And there are some dedicated devices available only for in-hospital use now. Because not all the CGM will be as accurate or safe as outpatient compared to the inpatient use, especially when there is an infection. And I also agree with him, agree with sir and also they are all not using an insulin pump. Because insulin pump usually requires, even for pregnancy, it requires 3 months of preparing a lady before she is accustomed to the use of an insulin pump. And this is true even for the AED. AED looks to be automated, but even for carb counting and for deploying the pump and for connecting the sensor and all, a little bit of training is required. So it won't be comfortable, and you have to respect the other doctors working in the hospital. That is the most difficult situation. The anesthesia doctor, the critical care doctors, the colleagues, they won't be comfortable using all these devices. But CGM luckily has become very popular, and this is part of workflow in most of the hospitals nowadays.
Thanks. I think we can now wrap up. And any question from the audience side? Any comment? No. Thank you very much for all the three participants. Thank you, Jyoti, for now this is your time to take the chair. Dr. Jyoti Keshadev, Dr. Nandini Chatterjee, and Dr. Ravindran A.V. Thank you. Thank all the three speakers. For healing and so this afternoon, for you syndrome. Yeah.
So shall we move on to the next session? So we are again back to Sri Lanka. So we have been to Sri Lanka very recently. So I have multiple friends in Sri Lanka. So Manika. And next is Dr. Dolano. So please, Dolano here, please. So Dunia is going to discuss on a topic, and the title is Navigating the Divine Challenge, Managing the Diabetes Patients with Thalassemia. A very relevant topic even in the Indian scenario when we are debating and discussing on the accuracy of hemoglobin A1C. In a large percentage of patients, the A1C could be wrong, and we go on the clinical practice and in the clinical trial only depending on the hemoglobin A1C. So this is a topic of very high relevance in the day-to-day clinical practice, and I cannot pronounce your full name, so over to Dr. Dulari. Thank you.
Good evening, ladies and gentlemen.
Yeah, let me introduce you. So I'm sorry. So she's a senior lecturer. She's among Sydney. She is consultant endocrinologist in the Department of Physiology. Her special interest is in endocrine complications she is having her original work in thalassemia, Graves' disease, and she has multiple awards and fellowships to her credit from the endocrinology at the Alfred Health, Melbourne, Australia. She is also the President's Award winner for the scientific publications. Over to you, Anna.
Thank you very much for the kind introduction, and good evening, ladies and gentlemen, and greetings from Sri Lanka. First, before starting this presentation, I would like to say a big thank you to the organizing committee for the invitation for both of us from Sri Lanka. And this is a topic close to my heart. I have been working with the patients with thalassemia for the last 10 years or so before I became a consultant. And during this past 10 years, I've seen many patients struggle with a lot of complications from thalassemia, a lot of complications from endocrinopathies, struggling to survive, and I've seen many die as well. So I think as clinicians, we have a responsibility towards, because their lifespan is getting now increased in thalassemia, it's our responsibility to make sure that we control their endocrinopathies very tightly to increase their quality of life and survival as well. So my topic is navigating the dual challenge, managing diabetes in patients with thalassemia. Bit of word about thalassemia. It's the most common inherited hemoglobinopathy with an autosomal recessive pattern. And it's a globin chain mutation that leads to thalassemia and caused by either partial or complete impaired production of one of the globin chains, which will lead to either alpha-beta imbalance, ineffective erythropoiesis, and chronic hemolysis. Alpha and beta thalassemia are the most two common forms, but they have E-beta thalassemia, thalassemia intermedia as well. It's very common in Sri Lanka as well. Out of these, beta thalassemia major is a form of thalassemia with a prevalence of about 1.5% of the world population. You can see it has a bit of a prevalence as well. And to talk about Sri Lankan burden, we have currently about 2,500 patients and estimated to give 40 to 60 new births per year. And as majority, 60% thal major and 30% E-beta thalassemia, and rest of the two other varieties. So I work in this HEMA's adolescent and adult thalassemia care unit attached to Colombo North Teaching Hospital, Sri Lanka. And that's the only adolescent and adult, both together, care center in South Asia, caring for about 500 patients of major, thal major, intermedia, and other types as well. To talk a bit about global prevalence, you can see the band of prevalence, and including the subcontinent, Indian subcontinent, and the sub-Saharan, and to the African and American, South American as well. The Indian prevalence ranged from about 2.6 to 13.2% in various studies, where North and I think West have the highest prevalence in India with the thalassemias. So why are we so worried about this connection? What is the connection between thalassemia and the endocrine system? First, to talk about that, let me talk to you about hepcidin. Hepcidin is a small peptide which inhibits the iron absorption in the small intestine, and both the ineffective erythropoiesis and anemia in thalassemia will result in downregulation of this hepcidin. So in spite of these patients having elevated iron stores in thalassemia, Reduced expression of hepcidin will lead to increased iron absorption for them from the intestine, causing iron overload. So this having dual pathology and increasing the iron overload in these patients. With this continued accumulation, the monocyte macrophage system gets saturated and excess iron gets deposited. Where does it deposit? It deposits in liver, heart, pancreas, endocrine organs such as pituitary, thyroid, parathyroid, adrenals, leading to tissue toxicity. So you can see, when I see a patient complicated with these endocrinopathies, it's like just reading a textbook from pituitary to thyroid to parathyroid, adrenals, all been affected. I've seen all of it in one patient in one go as well, developed subsequently during their lifetime. So by overloading these endocrine organs, which leads to cellular dysfunction, cytotoxicity, and ultimately will lead to cellular death. And chronic hypoxia and viral infections are also thought to play a part of this pathology, and deficiency of a variety of hormones will carry on depending on the organ affected. So these are the main endocrine complications we see in these patients: growth failure, hypogonadism, diabetes, hypothyroidism, hypoparathyroidism, adrenal insufficiency, primary and secondary both, and osteoporosis or low BMD depending on their age and sex. So this is a study done in our center, and you can see delayed puberty was the commonest form of endocrinopathy, and hypogonadotrophic hypogonadism next being 51.8%. Diabetes hanged around 16.3% of our population of TALS patients in our center. This is a group of medical professionals, international network on endocrine complications in thalassemia called ICET, where Sri Lanka is also part of this group, where our center gives data for these studies as well. And they have guidelines in managing patients with endocrine complications in thalassemia. So I'm going to get you to a case, one of the most interesting cases I had during the past few years. He is a 28-year-old male, had beta thalassemia since the age of 3 months, and developed hypogonadotrophic hypogonadism and delayed puberty at the age of 13 years, and subsequently developed hypoparathyroidism, and lastly developed diabetes about 3 years back. Before developing diabetes, he had impaired fasting glucose, which was diagnosed with the OJTT, but he was unable to comply with the advices. His serum ferritin was 2,500 when we diagnosed him with diabetes. Let me come to my talk on diabetes and thalassemia. It's a significant complication in patients with beta thalassemia, and the estimated prevalence, as variable, as I said, is about 16% in our population, but varies from 1% to 21% depending on the center these studies were done across the world. So what makes them diabetic, these thalassemia patients? The transfusional iron overload is the key factor which damages the pancreatic beta cells. And this poor compliance with chelation therapy leads to iron overload. And the advanced age where the chelation started also has an influence on this endocrine complication of diabetes. Apart from that, altered B cell insulin secretion and also autoimmunity had been found to have been playing a part, where they have found that immune system in thalassemia patients is downregulating, and their autoimmunity comes up, and they can develop type 1 diabetes in thalassemia patients. And specifically, the liver disease and the hepatitis C infection can cause insulin resistance, and this insulin resistance develops far ahead of developing diabetes in these patients over time, and then they develop diabetes. Family history of diabetes, of course, age, lifestyle, obesity also plays a role. So you might think thalassemia patients as short, lean patients, but no. I've seen many obese thalassemia patients as well, depending on their lifestyle, which they are having currently. So these are the main etiological factors why your patients with thalassemia can have diabetes. So how do we screen these patients? So this is usually seen after about 10 years of age, and monitoring starts around that age with 2-hour oral glucose tolerance test. We do the OGTT. should be performed at age 10, 12, 14, and 16, and annually thereafter. Can we do HbA1c? As our chairperson said, it's a controversial thing because we cannot, because they have low hemoglobin, and we're unable to do these test limitations. So we do fructosamine in these patients, but not for diagnosis, but mainly for monitoring purposes. But we carry on to OGTT. So what is the purpose of having a screening for these patients? One is early detection. We can diagnose them to have impaired fasting glucose. And also, if we diagnose them with diabetes, we can reverse it, because I've seen that if you control their iron overload and having a good intensification of their chelation therapy. So it is useful that we screen these patients and prevent them from going into frank diabetes. This was a study again from the ICET study published very recently about doing OGTT in thalassemia patients, published very recently, I think in December, where we also gave data where all publishers said some of the countries just do the OGTT as required, but few countries still are yet to do OGTT and still relying on their fasting blood glucose or postprandial blood glucose with diagnosis, which is not the correct way of doing it. So how do we manage these thalassemia and diabetic patients? As in all diabetic patients, lifestyle modification with good dietary modification, exercises, and pharmacological management. There are issues with dietary and exercises in these patients. They are anemic, and sometimes they go into low HbA of 6, 7 sometimes, and advising them to exercise during this period is not very healthy for them. And diet-wise also, they are restricting some of the iron-containing food. But when we ask them to control their carbs, they do that. But as Malka said, in Sri Lanka, having a big rice plate is very important for all 3 meals, and getting that reduced is definitely a challenge for us to control their portion sizes. So can we use drugs in these patients, oral drugs? Yes. There are studies that used metformin, glibenclamide, and acarbose in these patients, and mostly metformin. We use metformin as well in our patients with resistance, insulin resistance with facial features. We do start them, and especially for even impaired fasting glucose, we start it with the lifestyle modification to reduce the progression, and with type 2 to control the diabetes as well. And there is about 20 to 30% of patients with diabetes are managed only on oral drugs. But you can see that majority will need insulin because they have destruction of the beta cells and they are unable to produce their own insulin. So how do we monitor these patients? We need to screen them for end organ damage, similar to other patients, but we see less nephropathy and less neuropathy in our patients, and probably because they are having this gonadal dysfunctions as well, which can contribute to this factor. And the glycemic control is assessed periodically with home blood glucose monitoring. We do the glucose monitoring. We don't have CGMs in Sri Lanka at the moment. And the fructosamine target is 287, less than 287, which is equivalent to about HbA1c of 7. So this is to recap what the fructosamine and HbA1c looks like. You can see HbA1c 7 is 287 and 10 is about 400 of fructosamine. And there are studies saying that it may not correlate well as well, but this is good as we get in managing and deciding on their treatment regimes for us. Is there psychological impact? Yes, unfortunately, because these patients living with diabetes and thalassemia have major psychological impact due to feeling of treatment burden. They are on treatment for iron chelation, they are on monthly blood transfusions, and some are managing hepatitis infections, and some are managing other organic failures, and then coming with diabetes and 3 or 4 insulins a day. It makes their life hectic. Impact on daily life, feeling of difference, dependence, a feeling of damage and anxiety is among the psychological things we need to consider in our patients. So I'm continuing my case. He had a fructosamine of 467. That was about 6 months back. He was on premix insulin. You can see high doses, 45 units twice daily with a soluble for lunch with metformin. But later we could change them to the basal bolus regime. That's from a donation from Australia given for young children. And he was enrolled into this and young adults. And he was given the basal bolus regime, but still with poor compliance. He did not manage his diabetes well, missed his lunch doses, and so on and so forth. What happened very recently was 2 months back, he developed acute coronary syndrome. Young patient, 28. He had T inversions in anterior and inferior leads. Troponin was positive, but his 2D echocardiogram showed no LV dysfunction with mild TR only. So what are the causes for this cardiac disease in beta thalassemia? Multifactorial, iron overload, chronic anemia, hemolysis, inflammatory factors, immunogenic factors. All of that will have them to have cardiomyopathy, pulmonary hypertension, arrhythmias, premature vascular aging and peripheral artery disease, and sudden cardiac death. And I've seen many patients die of cardiac complications when they're iron overloaded, and especially when their diabetes is not controlled. The challenges I've encountered and thought I would like to share with you in this audience when managing patients with diabetes and thalassemia is the compliance to treatment, because they have issues, as I said, with their chelation therapy and diabetes. It's very challenging to convince them to get into regular regimes and getting them to regular clinics. My patients come far away from all the corners of the country to one center for monthly transfusions and for endocrine care, and it's exhausting them. Behavior of the disease is variable among patients. One patient to one patient is so different, and individualizing your management is the key. And these patients have rapid blood glucose fluctuations, are very unpredictable. I currently have a patient who goes into 20 of blood glucose at night and 400 at lunchtime, and on analog insulin from a donation, still going into severe hypo. I think she would benefit from having a pump, which we can't afford at the moment. So rapid fluctuations are there in thalassemia patients. And these patients have poor immunity due to hyperglycemia, and which leads to increase in their mortality and morbidity both. And this immunity needs to be increased with controlling their hyperglycemia and controlling their iron overload. Of course, the poor resources of we are getting free treatment for these patients. Only we can afford to give the mixed insulins and a soluble. We cannot go for basal bolus regime, which would have been the ideal for all patients with thalassemia in our country, but it would have changed some of the patients' lives as well. I'd like to acknowledge Professor Anuja Premawardana. He's a key consultant physician looking after these patients. He's a professor of medicine in our faculty, and all the staff of HEMA's Thalassemia Center, which is doing a wonderful job with these thalassemia patients, caring for them with their diabetes and all the other complications, and to all the courageous thalassemia patients who are surviving in a day-to-day basis. And we can stop thalassemia. It's mainly due to consanguinity and genetics that we have to advise them to go for the testing prior to their marriage, and to improve this knowledge across. We have a lot of preventive programs in Sri Lanka as well, so we can prevent thalassemia and prevent the endocrine complications and diabetes as well. This is from our website, from our unit. This is written by one of the patients. Yes, we are thalassemian, but we want to live long lives. Thank you for listening.
Thank you, madam, for your excellent presentation. The discussion will be at the end of the session. So the next topic is learning from 3 real-life cases to improve diabetes management. To talk on this, we have an eminent speaker, Dr. Jyoti from Nepal. She's a highly esteemed senior endocrinologist at Metro Kathmandu Hospital. She is certified by American Board of Internal Medicine and subspecialty of board certified endocrinologist. She completed her MD in internal medicine and fellowship in endocrinology at Upstate Medical University, New York, with her exceptional qualification and specialized training. She is dedicated to providing comprehensive and compassionate care to her patients, contributing significantly to the field of endocrinology at Metro Kathmandu Hospital. Over to you, ma'am.
Thank you very much. Thank you, organizing committee, to give me this opportunity to meet with you. I'm a small country sandwiched between the two diabetes capital of the world, China and India. And I take the brunt of that and see lots of patients as you do. And even though it is like a run-of-the-mill cases, these are quite fresh. And every day I'm seeing young patients with diabetes. And I think in this conference, we are focusing on the young people. So I should have, I got his permission. And this is the photograph that my patient took from his file and shared with me. And I took his permission to share his story. I saw him like 5 months ago, 36 years old male, IT technician. And I tell him, he's doing all this and not any other rest of the exercises. There's no family history of diabetes and there's smoking. And presenting symptoms was dry mouth, fatigue, tingling sensation on his feet, and few kg weight loss. And the physical examination, he was a little bit anxious, 120/90, but the pulse was 82. The BMI was 20, and the rest of the examination was normal. But the hemoglobin A1C was 14.8, and the urine ketone was negative, and the C-peptide was not very low, not very high also. And the GAD antibody was negative, even though he was a BMI of 20. There was only mild fatty liver. And we started him on basal insulin because the HbA1c was high because of glucose toxicity. And metformin was initiated. And with lifestyle and dietary counseling, a 1700 kilocalories diet was recommended. An increase in protein and decrease in carbohydrate intake was recommended. So progression over the 1 week period showed that the blood glucose slowly came down, but it was in the 181 to 300 range. And, repeated food history revealed that we have talked a lot about carb, and in reality, it is not enough to just educate the patient once. And sometimes we health professionals get exacerbated and say, I told him many times, but he didn't follow. So nowadays, my assistant has to sit down with each and every patient and get food history. And then we figure that the only food that we are in our context is eating is only carbs. And this is a young guy who's only using his brain and his hand, and he's not doing his muscle activities, and talk about muscle building and all that. So over the period of time, after repeated diet histories, slowly his blood sugar started improving. Linagliptin was added and basal insulin was tapered off. The last time I saw him was on Monday. His fasting blood sugar was 95 and the postprandial was 116. HbA1c came down to 5.9%, and the weight was stable at 53 kilos. And I again stressed to him the need to improve his muscle mass and physical activity and resistance training so that he can sustain his blood sugar control. So that is the takeaway for this patient. Even though we have not very high BMI, we have GAD antibody negative, not insulinopenic, but not severely insulin resistant young people with diabetes. And we are all seeing that day in and day out. And through this case, I want to highlight, even though its learning point is old, diet improvement is extremely important. And patient number 2, I didn't have his photograph, so I did from the AI. And he is very dear to me because he's the son of my classmate who died recently. He is a doctor himself, 34 years old, again, I took his permission to talk about him. He did his MPH, he was doing his MPH and he was bicycling in Indonesia. And he had 8 kgs of weight loss. And polyuria, polydipsia, extreme fatigue, and he took the flight to Kathmandu, and his dad came with me. Now you take care of my son. He has diabetes. I don't know what to do. He had no nausea and vomiting, only weight loss. And examination showed that he was a little hypotensive, dehydrated, and his BMI was 21.9. Lab parameters showed slightly increased creatinine. and his C-peptide level was very low and GAD antibody was high. And as usual, he was admitted, IV hydration, treated for DKA, and the patient was switched to basal bolus insulin and then overlapped with the insulin pump and then, insulin infusion and then stopped. And this was the sliding scale, both nutritional and correctional, along with the basal insulin. And this was given to him. But again, he had repeated visits, visits bringing the sugar readings. And I wish we have easily, yes, we do have insulin pump, but when somebody is CGMS, but when you are just upfront and learning with a new diagnosis, I think I can't just jump to the insulin pump. I have to get some stability with basal bolus therapy and very, very variable blood sugar, but with repeated admissions and his own learning. He did a lot of learning himself, started doing resistance training and repeated visits, and doing like an investigative journalism. We could get to the some kind of sensible readings, even though we don't have CGMS. His readings got better. And in the interim, my dear friend did not have diabetes-related kidney disease, but he had some another severe kidney disease. He was admitted in the hospital for a month. The son was under stress, and eventually in this process, I had to lose my friend, despite the doctors trying everything. And his son, who's my patient, despite having this challenge of having a funeral in the family, we have horrible food during the 13-day period. He somehow managed to, even after the 1 month after his father's demise, the young man came to me with good sugar readings, and finally the dust had settled, and I had strongly encouraged him to keep his muscle active, and along with the carb consistency, he had mastered the art of carb consistency, and also the importance of the mixed meal for his overall health. And not only him, I had come across a year ago, I don't remember the professor. The professor came with a bunch of 9, 10 young in their 70s to 30s years of age, type 1 diabetes on CGMS as well as insulin pump. They were from France and they went to Nepal. Nepal is famous for trekking routes, and they had done a pretty rigorous 10 days trekking route, and they had presented to us. And absolutely the sugar control, the CGMS showed beautiful reading despite walking in the remote part of Nepal. So type 1 also, the dietitian was in the team, the own doctor was on the team, the physical therapist was on the team, and they had been really trained well, and most of the people were showing excellent reading. So even in type 1 person, even though it is like a no-brainer, the carb consistency, the properly nutritious food, dietitian, food history, physical therapy, and it's very challenging to give all the comprehensive care. 20 years ago when I was practicing in the US, the doctor had to do the counseling, and there were counseling teams, but they were not reimbursed. So if you don't reimburse, it's not going to be sustained. So with that analogy, in our country, many of our government settings don't have any physical therapist, any dietitian. One doctor is seeing 150 patients every day. So how can we talk about, comprehensive, compassionate care in our settings? So I want to raise this issue with you, and, together I think we should give value to the young doctors and young nurses who are working in our country, so that they stay in the country and they give proper service to these people, so that down the road they don't get into all these nasty, expensive complications of diabetes. So the learning point here is type 1 can occur in adults too. Again, it is important to have the muscles working. It is important to give the proper nourishment to the muscles. Resistance training is important, and of course you need comprehensive care model, chronic care model to help empower this patient. Now I'm coming to the third patient, who is a female, 34 years old housewife. Her BMI is high. She had type 2 diabetes for 4 years, 7.9 on metformin. Intervention was 1,000 kilocalorie per day traditional Nepalese meal diet, and it had all the balance of the protein, fiber, and everything, fat. And the medication was, the metformin was stopped because she was part of the direct study. The direct study that Dr. Manilka had talked about, that Michael Lean had proven in the Scotland. We did a one-arm translational study in Metro Hospital where I worked. And her hemoglobin A1C reduced from 7.9% to 6%. The fasting glucose normalized. There was moderate weight reduction of 3 kilos over the last 3 months. And the patient remained off of metformin. There was sustained glycemic control. The key insight is type 2 remission is achievable through cultural dietary adaptation. Though in the original direct study in the Scotland, they had used total replacement meal. Here we had Nepalese appropriate, and this is a glimpse of that diabetes remission study. You are more than welcome to go and read yourself. And this one is comparable to the kind of food that is recommended in Scotland after that direct study showed that 40% people could achieve remission in type 2 diabetes. The Nepalese diet is below this, portion size, portion size, portion size. And with Professor Michael Lean, we are still working on another translational study in which we are applying this in community level with the active participation of the local community leaders. It is about to start this very week. And this is the recommendation that we are going to do. And I will be really, really excited to share that data. But this one, the hospital-based study result was already published in October in Lancet Southeast Asia. And we had achieved about 30% remission rate. And this is the girl who participated in this, and she was quite happy. We had done interview with her, and initial resistance is there. But eventually she was happy and she was enjoying the feeling good. In the interim, I also developed diabetes, and I am also following the same principle of improving the muscle mass, a healthy, balanced diet. And I also did the CGMS, though unfortunately not everybody can afford the CGMS. And I feel good, but unfortunately there is a bulk of our young patients who are suffering, bulk of the doctors are suffering because they are just, bombarded with patients in the clinic. And you cannot do this acute care model and, bend your hand and write 1 or 2 prescriptions. You need comprehensive, consistent, repeated care. And there's so many success stories. There's so many sad stories. We all know the kidney failure, the eye damage. It is very devastating. But upfront, if we do the legacy, if we do the upfront control, we can do the legacy effect. And I want to be hopeful, and I want to, aim for the best. So persistent care team, compassionate care, consisting of pleasant personality, managing your stress, working on your exercise. Exercise can't be just general exercise. It has to be with the resistance training and a healthy diet, and that delivered through multi-team effort. And we really have to seriously think how we can deliver in our national level. And I would really, really hope that we can sit together and bring something like that, and also work on the primordial prevention and primary prevention. I think I have come to the end of the slide, and I really appreciate your patience, whomever you are here left. And I'm really glad that some of you are still here because this is the last session. And this is a Himal called Nilgiri Himal, or mountain. It is close to Muktinath temple. And I was there like 2 months ago for a short trek, and I welcome you. And this is the painting that I did myself. So I would like to welcome you all to come to Nepal and enjoy our mountains. And I really appreciate your patience.
Okay, excellent presentation, and all the 3 cases very unique. And I would like to congratulate you not only for the lecture, but also being board certified in internal medicine and in endocrinology, and coming back to your hometown, coming back and working in Nepal. So that itself is a big thing. And we share the same name. I am also Jyoti. So next is a very important speaker. Very, very important speaker, and this is Dr. Mohammed Ed Sandit. And I will read out the CD. He's also representing IDF and DASG. And he's speaking on increasing diabetes in the MENA IDF region, causes and solutions. He's a neuroendocrinologist, Paris 6 University, founder and president of the Lebanese Diabetes Society. He's also the manager of National Diabetes Program, reporter of the National Diabetes Committee, former member of the Executive Board of the Endocrine Society, Professor of Internal Medicine, currently at the Lebanese University, member of ADA, Middle East Insulin and Neuropathy Working Group. And of course, he's very, very active in the DSG. Member of the Steering Committee of Arab Group Diabetes Studies. He has been involved in multiple clinical trials, researches in the same space, and he's the main organizer of the very popular Diabetes WS education, held under the patronage of the Ministry of Public Health and World Health Organization. And we are very honored to have you here, sir. Over to you, please.
Thank you for your invitation. This is my conflict of interest. My agenda, I want to talk in summary, brief overview of the International Diabetes Federation, mission, vision, and objective, the burden of diabetes worldwide and the MENA. Why is this increase in diabetes in MENA region? How is MENA IDF facing these challenges? And conclusion. As you know, the IDF short brief for the Global International Diabetes Federation. The IDF, a vibrant federation. It was founded in 1950. It includes 170 countries, 230 members, and we have 7 regions. MENA, it's one of the regions. Why IDF? Global community for people with diabetes, powerful voice. So the 3 main IDF mission: epidemiology, public health, education, prevention, access care and care. Okay, thank you. So we have Atlas, a global burden, research, and we have school of diabetes, education modules, guidelines, resources, prevention, research, etc. The right of every diabetic, every person should have the same access to the same quality of diabetes prevention and care. Every person with diabetes has the right to an early diagnosis, education, treatment, and prevention. I want that. The International Diabetes Federation is in the pocket of every diabetes patient worldwide. Companies that need money because of people with diabetes should fund diabetes advocacy. So diabetes has many faces. The Global Diabetes Survey will powerful of this faces. Second item, the burden of diabetes worldwide in the MENA also. The figures that I will show come from the last IDF Atlas in 21. We developed the last Atlas in Bangkok next month. So number of people with diabetes worldwide per IDF region in 2021 and 23 and 2024. So as you know, in 2021 we have 537 million, in 23 and 30, 643 million, expected to be reached 784 million in 2045. In the MENA region, the higher percentage, it's increased by 87%. Unfortunately, we have 3 times more in 20 years. In MENA region in 2000, we have 55 million, now 73 million, in 2023, maybe 150 million. So in 2021, IDF Atlas estimate 1 in 10 adults between 20 and 79 years has diabetes, 537 million. 1 in 18 adults between 26 and 79 years has impaired fasting glucose. 1 in 6 die. 3 in 4 people with diabetes live in low and middle income countries. 9% of 11.5% health expenditure spent on diabetes. We have 6 million 7 deaths related to diabetes. So 167 million adults with impaired glucose. We have 7,000 more pregnancy attached by hyperglycemia. And 1 in 2 people with diabetes know they have it. And 1 in 7 births is affected by gestational diabetes. 1 in 12 people today has diabetes. So every 12 minutes stroke, 19 minutes myocardial infarction, 90 minutes in amputation, 60 minutes in new cases of dialysis, 90 minutes in new case of blindness. So we have 5.1 million deaths per year. What is diabetes in the Middle East and North Africa? As you know, the MENA region have 22 countries, 31 associations. The founder of IDF MENA, the 3 musketeers, 1 from Egypt, Professor Morsi Arab, 1 from Pakistan, Professor Samad Chera, and from Sudan, Professor Dawa. So diabetes burden in MENA, adult population aged between 20 and 79 years in 2025, 448 million. In 2030, 540 million, expected to be 703 million. Diabetes MENA prevalence, 6.2% now. In 2030, 19.6. In 2045, 20.4. Number of people with diabetes, now we have 73 million. 73 million. In 2030, 95 million. In 2045, 136. Number of diabetes due to deaths due to diabetes, 8,000 per year. So this slide, this is this list, top 10 for diabetes in the world prevalence. As you know, Pakistan number 3, Egypt number 10. So we have 2 countries in our MENA in the top 10 list. So 1 in 3 people living with diabetes in the region are undiagnosed. Diabetes is responsible for 796 deaths in 2021. And so the prevalence of diabetes mellitus in our region is very high. The highest prevalence among the 7 IDF regions. Now, unfortunately, it will remain higher by 2045. So it is catastrophic. Now, in 2019, diabetes-related health expenditure in the MENA, 25 billion, expected to increase by 2030 to 33 billion, and by 45 to 39 billion. So diabetes prevalence percentage in adult between 20 to 70 years in prevalence
Yemen is the lowest, Pakistan the highest. So top 10 country prevalence: Pakistan, Kuwait, Egypt, Saudi Arabia, and Sudan. So PWD and countries affected by disaster by million. As you know, Iraq, Syria, Afghanistan, Yemen, Palestine, Libya, Lebanon, Pakistan, Iran. So this is a region of most disaster of all the 7 regions. 1/3 of the population of the MENA region are living and having disaster. So one of the important challenges we faced in MENA, delivering insulin to young people in Gaza, in Lebanon. About the metabolic syndrome, the MENA region is known for its high prevalence of metabolic syndrome, remain from 17% to 49%. So MENA region, the tsunami diabetes area, 450 million adults, 73 million patients with diabetes, 150 million diagnosed, undiagnosed, and pre-diabetes, and 49 million PWD affected by disaster, 17 million short of insulin, expected growth 87%, cost $33 billion. So why is this increase in diabetes in MENA region? So because 80% of diabetics type 2 are obese in the MENA. Obesity, the neurocensory epidemic. What are the root cause of obesity in our region? The misconceptions. Obesity, a symbol of affluence. The revolutions that have changed human life, like agriculture revolution, Gulf countries, the discovery of oil, changing lifestyle, diet and physical activity, the prevalence in modern society of many chronic disease is the consequence of a mismatch between our modern diet and lifestyle and our Paleolithic genome. So the main risk factors in our region: discovery of oil, a lifestyle change. So also the smoking, it's very high in our society, in MENA region, in the West circumference also. 80% of people with diabetes in our region live in low and middle income countries, except Gulf. How is MENA IDF facing the challenge? We need to stop diabetes. What we have to do to improve the life of PWD, stop or slow down this evolution in our region. So diabetes is changing the world. How can we change diabetes? By prevention, early detection, and effective treatment can make a difference by eat healthy, exercise, and treatment. 30-minute minimum walk each day can reduce the risk of developing type 2 diabetes by up to 40%. So people with diabetes deserve a better life. So we need understanding patient need. 3 out of 4 people with diabetes suffer from the impact of the disease on their mental health. So this year, the World Diabetes Day theme of the year, diabetes and well-being. So recent studies on people with diabetes have shown that 36% of people with diabetes suffer from psychological stress due to diabetes. 63% of people with diabetes are worried about the impact of diabetes complication on their health. 28% of diabetics find it difficult to be positive about the situation. So from theory to practice, you need to implement the UN resolution issued in 2007 by the General Assembly. The main objective of the UN resolution: increase investment, expenditure resources in diabetes care, improve access to better diabetes care, promote more effective education for healthcare providers, lower the rate of increase of diabetes prevalence, create a national diabetes program in each country. So the way to a national diabetes program, obligation of different party, minimal requirement, and national diabetes registry, etc. Governance, contribute to the improvement of the governance of each association. We execute turning MENA country and all MENA members, guidance workshop in Syria, Kuwait, Qatar, Yemen, Lebanon, Jordan, Iran, Sudan, etc. Sharing experience between MENA association and our region. We have many agreement collaboration between the association. So encourage national diabetes plan and program. Priority objective in MENA region, reduce diabetes prevalence, better access to quality care, and the prevention of complication, prevention, health promotion, education, screening, early detection, and intervention research. So we have many screening awareness campaign in all member of the region, the MENA. This is an example about the screening and development of material in two languages, English and Arabic. Recently, we launched a book about diabetes and pregnancy in Amman, in Bahrain, in Arabic, in Pakistan, and English. So training, many training about diabetic food, diabetes in Ramadan, etc. Access to care, it's very important in case of disaster. So quality of care, diabetes education is very important. IDF, young leader in diabetes in camp. Now, what is the barriers preventing access to diabetes care? Insufficient resource and insufficient system to ensure access to essential medication and diagnostic, an effective system to ensure uninterrupted supply of insulin and supplies to those who need them. 50% of people with type 2 diabetes who need insulin do not have access to it, etc. So in conclusion, we are facing now many challenges in our region. The prevalence increasing of diabetes, high rates of complication, unhealthy lifestyle modification, expenditure of diabetes treatment are very low in some countries, lack of education and awareness, disaster, and the MENA plan these with problem need to work together. Thank you for your attention.
Thank you. Thank you very much, Dr. Mohammed El Sandi. It was like a story. Please occupy the chair. So the other speakers also need to come here, Dr. Dulani and Dr. Jyoti. Please occupy. So now we are open to questions. It is a quality audience. I will request all of you to come up with your comments and questions to the speakers. It is so unfortunate that even after 100 years of discovery of insulin in the MENA region, even in many parts of India also it's the same. More than 50%, as you said, die of unavailability of insulin. So unfortunate. And you have been actually discussing the solutions as well, how we can overcome and what are the challenges. But don't you think that convincing the doctors in many parts of the world on the early use of insulin, on the early adoption of some of the cost-effective technologies, which we are failing, convincing the doctors. We always say that the government is not agreeing, the policymakers are not being convinced, but don't you think that we are also failing in convincing the doctors and those who are really treating the patients? What is your
unfortunately, the main problem in our region, access to treatment in very difficult situation like war in Gaza and Lebanon, etc. I invite Professor Musbah to explain because he is responsible for the disaster committee Please, Musbah.
Thank you very much, Professor Sunday. And thank you for this question, sensitive question, I mean, because the affordability and the availability of insulin have many challenges, especially in Middle East. As you know, insulin is a sensitive material. It needs a special environment. It needs special handling, and all the conflicts, I am sorry to say this, are reflected on the availability of insulin. And I think one of the utmost needs, and for a human being, all of us must raise a voice that nobody needs the insulin, should prevent from getting it. That's the right time and the right quantity and with the special maneuver. But you have to deal with the matters on the ground. So we try to secure some of insulins through the Red Crescent and Red Cross and the WHO, but the barriers from the other side prevent us from delivering this. And sometimes you have the insulin at hand, spoiled, and you have on the other side people who are craving for insulin died because no availability or getting complications.
Very, very, very unfortunate situation, sir. Very, very unfortunate. So sometimes you have the insulin, but the insulin is spoiled because you cannot store the insulin. There is no cold chain maintained.
Yes.
Very, very sad. Very sad. We don't have a solution.
This is a political issue. What can we do? It's not unhuman.
And more than, according to sir, more than 35,000 people are dying of lack of insulin. That is what you said.
Yes. All of us must raise a voice that mankind disaster should not prevent people from getting the utmost of care, and on the top of it, the medicines like insulin.
Okay, I understood. So I can imagine the plight of people with type 1 diabetes, because I'm sure that many will be having type 1 diabetes as well. So any questions from the audience? So I have a question to Dr. Jyoti. We were discussing about one boy with type 1 diabetes. Yes. And don't you think that this could be a honeymoon period, and do we have availability of CGM? Do we have availability of CGM in Nepal? Is it?
Yes, it is available, and we can easily, definitely, it could be, and the need to follow through, but he's not completely, controlled without insulin. He's still on insulin, but the insulinologist coming and awareness building up, I can see that it is changing. But the burden of the disease itself is so high that, the government is kind of getting, smarter or, getting better. And in one of those lectures, I'm saying, there's no comprehensive care, and one of the physicians will come and say the care is better. For him, the care was better because now the medicines are available through insurance, so it is free, and the care is better because the labs are cheaper. But that is not enough. You need comprehensive care, meaning you have to get to the inside the skin of the patient. I'm fortunate that my husband is a psychiatrist, and in our team we have a 5-6 bunch of psychologists and psychiatrists. So it is a painstakingly long process, and if the patient is just thrown in a busy government hospital, he'll be lost, and 10 years down the road he'll come with a complication. So we have to do the paradigm shift and have our specialists stay in our country, pay them well, so that we pay the doctors for health maintenance rather than paying for the disease treatment. That is my
I think
it was challenging, but I feel
but you feel more satisfied.
Yeah, very much satisfied.
Very much. I can understand that, because the US will publish the American Diabetes Association guidelines, but they may not be able to implement it. And for acute emergencies, many a time the patients have to wait for 6 months to get a endoscopy done or to meet a neurologist, and that is not the case in our country.
Yeah.
Yes, it's much
So
better,
we have plus
far
and
better.
minus. I think we should be proud of what plus we have and improve the negative that we have.
Absolutely, absolutely. So I have, because, yeah, please, yeah.
We need local guidelines in all our countries, switching our culture, our resources, and reprioritize our needs. Because guidelines, okay, this is a matter, nobody can go against the guideline. But the implementation is very important. So we want to rearrange our needs according to our resources and according to our cultures, according to the needs of the patient, what is affordable, what is not affordable, and give more and more and more to patient education, like Muhammad said now, education, 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 because this can fill the gap between what we have and what we need.
Yes.
Otherwise, the diabetes care will not be improved in our countries.
I'm proud to share that we also have started developing the school health manual that connects the community farmers to the school, and that links with the lunchtime feeding with the knowledge about the non-communicable disease in that, and we want to train the, senior school kids from the beginning. So I think we need multi-pronged, in everywhere we have to attack, go in the attack mode.
Yeah, please. You introduce yourself.
Yes, sure.
Yeah.
Hi, everyone. My name is Manish Arora. I'm from Indian Institute of Science, Bangalore. I'm not a doctor as a medical practitioner.
But he's an innovator. He's an innovator in technologies, insulin pumps.
Looking at medical devices and including insulin pump. But the question is more on in our countries, especially in the tropical region, the temperatures are quite high. I just wanted to know if you are aware of any solution where insulin potency can be measured at the point of use. Can the patients or doctors find out whether the insulin they've been carrying with them, are they functional? Are there any solutions for that?
Oh, your question is whether you can test the potency of insulin, whether the potency is lost or not.
Yes.
I am not aware of any such technologies. Yeah.
But I haven't read in detail, but I've been aware through my esteemed Indian colleagues that the potency is kept quite well, even in Indian context. So if you keep it away from the direct sunlight, if it's in the pen. But I think it will be cumbersome it will be a technological thing. But in reality, if the insulin is working, you know that it is potent. That is a common sense.
But his question is how to measure the potency.
Yeah.
That I don't think
Even if
anybody
you go in the research-based, insulin clamp will assess the potency, but it's too costly to do.
Yeah, too costly. The question is in a community setting, because Sir was discussing about loss of potency and people dying.
Yeah.
So if there is something to measure the potency, only after injecting we will get to know that this insulin is not working.
Right. So only
or 40% potency. Yeah. Baron Lee, please. Dr. Baron Lee is from Singapore. Please, you will have some
Strangely from Singapore, but
Singapore, yeah.
Actually, Novo Nordisk did studies of this many years ago. As you know, they're active in Africa, and they were doing stuff like the Zea pots for places with no refrigeration. There have been decline curves that were put up at different temperatures. So it's historical data. Professor Kaushik Ramaya from Tanzania tells me that for a lot of his patients who go on the Hajj and so on and so forth, they do have some form of estimation. In other words, it's not so much a test, but the clinicians who roughly know how many % of allowance you have to give.
But that is only after injecting.
But then, it's so... For a group of patients, you would roughly be able to tell. Because what our friend who was talking about the insulin pump is really discussing is, have you got some form of at least a design parameter? So the other thing that I would say that would work very well would be the CGMS. So with the CGMS, you can pretty much work out a decay curve or potency curve for that patient, for that batch. But yeah, that first injection is a trial and error one with some predetermined parameters.
Because he is an engineer and his question was very precise. It is before injecting. Your question is how.
So what he wants is commonly.
Dr. Manlinga, yeah. Manlinga is my good friend from Sri Lanka. Yeah.
No, we also practice the pot, clay pots. People don't have refrigerators.
Absolutely, yeah.
We get donations of insulin. So we have a clay pot with water and a polythene bag and another smaller pot, which is immersed in that. And they maintain roughly the temperature, below 30 degrees Celsius. And of course, by practice, we know people who don't have the refrigeration, there may be a certain reduction. So we have a 5 to 10% escalation of the dose preempt. You have to have
you will assume it and
proof of the pudding will be in the eating. So I mean, within 2-3 days, if you measure, if you have a doubt, it's a matter of checking 2-3 capillary sugars, and they will know it shoots up, and then they come back and say this vial is not working. We do that all the time.
Hope it answers your question. But
so actually, he says generally whether we have potency to measure. Even if you get something to measure the potency, what they all are saying is now how to maintain the potency. But even if you know the potency through somebody, it's going to vary from individual to individual. So generally we can't say how it is going to.
Very right. Thank you, Dr. Pramod. I have a question to Dr. Dulani. You said that with thalassemia along with diabetes, diabetes remains uncontrolled and this increases the chances of infections. So in diabetes, we have routine vaccinations being advised. We have yearly influenza vaccine, you have a conjugate vaccine for pneumonia, polysaccharide vaccine, and then a booster for polysaccharide. Then now we provide a herpes zoster vaccine. So do you have any recommendation in thalassemia similarly with diabetes?
Yes, we do that with thalassemia patients as well. So these patients who have got splenectomized, they are already on pneumococcal vaccine, and it's not recommended now worldwide being splenectomized for thalassemia unless it's really critically needed. But the rest of the patients, we give the influenza vaccine yearly for like uncontrolled diabetic patients, but not for all patients. Yeah, it's not free of charge at the moment.
So do you think that you have a resource limited setting in Sri Lanka and you're finding it difficult to, am I right? So
Yes.
Because if you are using technology such as CJ, it will be very easy for you.
Yes, absolutely. I mean, it would do wonders to thalassemia patients. There's a lot of fluctuations in blood sugar, and managing them is so difficult for us. Even getting glucometer strips free of charge is a challenge for us. We give it through donations. It's not funded by the government. So getting a glucometer, getting strips.
Glucometer strips are also not funded by the government?
No.
Okay.
So it's itself is a challenge. We have donations, getting them into all this. So it's pretty a big challenge for us. CGMs are a way out of for us at the moment.
So that is what I said in the beginning. Even after 100 years of discovery of insulin, we couldn't provide the same level of care to everyone. Any questions? Dr. Yasin, your comment? Because we have long experience working in the Middle East.
Yes, sir. Yeah. So I would, I have my condolences to the people who are suffering in Lebanon and Gaza. So yeah, that's the thing. Like insulin, the current situation there, it's making it difficult for keeping the insulin in the cold chain. But even sometimes I feel like people from Saudi and UAE, we have a lot of patients from Saudi and UAE, they come to Kerala because we are from Kerala. They come there and then they buy insulins in bulk and they go back because the availability sometimes is difficult in some places in the distribution. Because in India, we have a lot of manufacturing going on with insulin, but I'm really surprised why it's not that much there in Saudi, UAE, where they don't have the financial issues. So like some patients, I think Susa would have something to say.
I am worried about another scenario. We have 3-4 minutes more. That scenario is human insulin manufacturing is getting almost over. Because these bulk manufacturers and branded companies, they are now focusing only on GLP-1 based therapies. So human insulin will be a product which is only a biosimilar in future. Soon in the future, it might even vanish. Sir, yeah. Yeah.
Being an advocate for our people with diabetes, one of the sad news that Novo Nordisk will stop the conventional insulin production and going for the analogs and GLP-1. And I think we must raise a voice, and we discuss this in a very impressive way in IDF, that this will not be the way to get more money for what? For the humanity. We'll still use the conventional insulin in our countries because of the resources. So I think all of us must give this notice.
Any responsible for Novo Nordisk in this room? No? I want to ask why Levemir will be stopped.
In fact, I spoke to them. And their answer is, earlier they were annual insulins, and now annual insulins are completely obsolete because since the newer insulins are there, they thought that there is no need of annual insulins, and there was a protest which was, they said that the protest was much more than the protest now, when annual insulins were stopped. And now there is no need of human insulin because analog and newer analogs are there. And that is one of the reasons they are actually stopping the manufacturing. But I know that it is because of other reasons, because they need the same facility for manufacturing the...
No, I think it's Ozempic. No, they are not telling it. They lack facilities and capacity to produce the huge demand for Ozempic, and they are converting some of the factories doing Mixtard and the human insulin.
And the same is happening in India.
GLP-1 receptor agonist. So it's all a business.
Any more questions?
I will request only Ravindra answer for a comment because we have been working in the Middle East. Oman.
Oman, currently there is no issue with the availability of insulin. But the thing is that compared to cost here, it's more costly there. So people who are coming from here, especially expats working in Oman, they used to bring insulin and other medications in bulk for 6 months and all. If there are no more questions, we will conclude the session. I thank all the speakers for their excellent presentation, and I thank the organizers, especially Banshi Sabu sir and the team, for giving us the opportunity to be here. Okay, thank you.